and the testing infrastructure is now well established. But there are still concerns about the budget, concerns about how test and trace will cope with the future, and concerns about generally reliance on contractors and some of the other financial issues. So we're delighted today to welcome as guests in the room with us, which is a nice change, Sir Chris Warmold, who is the Permanent Secretary at the Department for Health and Social Care, so a regular visitor, but usually recently or more online. Dr. Jennie Harries, the Chief Executive of the new UK Health and Security Agency, and Baroness Dido Harding, who is the Chair of NHS Improvement, but is here in her context as the former Accounting Officer for Test and Trace. Online, we have Shona Dunn, the second Permanent Secretary at the Department for Health and Social Care, and Jonathan Maron, the Director General for Public Health at the Department for Health and Social Care. And I'm delighted that we're joined today by Greg Clark, the Chair of the Science and Technology Committee here in the House of Commons, who is a guest on our committee today. Before we go into the main session, I just wanted to ask you some questions, Sir Chris, about the letter you sent us in response to our request for information about care home discharges. And I mean, in summary, the letter says it's a lot less certain about the testing levels that can prove that people had COVID when they left hospital and went into care homes than we had perhaps been led to believe before. It goes into a lot more detail. Would you like to comment?
Well, I'll give some comments and then I'll hand over to Dr. Harris, who has been looking at this both in her previous capacity as Deputy Chief Medical Officer and in her current capacity. Now, first thing to say is obviously this is an incredibly important topic and is worthy of deep scrutiny. And I know Mr. Clark's committee has been looking at this as well. Now, we are not saying, and I want to be very clear about this, that the PHE study you were asking about is the definitive story here. This is a matter that is still under scientific debate. This is one contribution to that scientific debate, but there are several others. Now, what we will say, however, is though that scientific debate has not concluded, and there will clearly be a lot more study of this important question, all the studies we have at the moment are pointing in roughly the same direction. We have, as we quoted in the letter, a study from Scotland and a study from Wales using different methodologies that all point in the same direction. I think there are some others as well, and we don't currently have studies pointing the other way.
And when you say the same direction, you mean community transmission is what you're saying is more the reason?
That discharge from hospital was not a particularly significant vector of transmission in this case. I mean, they point to various things, but mainly community transmission. So the importance of this for us is this as a part of a number of studies, and to get a full picture, we clearly have to look across those studies. So I'll turn to Jennie on the specific questions you're asking on this study, but I wanted to put it in that context, and as I say, make very clear that we don't think this is the end of the debate. We think there is a debate that is pointing in a very clear direction, and we don't have any evidence going the other way at the moment, but just formally for the record, that debate has not concluded in the scientific community. But Jennie, do you want to...
Dr. Harris, as well, we're having the debate, but it seems that the data is inadequate to actually really give a very clear story on this.
So I think the data is difficult in adult social care, which I think we've learnt through this exercise. And in fact, what's in the letter are a number of studies. So some of the best data actually is Wales. They have SAIL data, which has very good linkage across community data. But nevertheless, the PHE study looked at those cases who were confirmed positive, and I'll come back to that because I realise that's one of the potential critiques, and followed them through to see which associated cases there were in care homes. And at the time that study was on, I was actually chairing, as in my previous DCMO role, the care subgroup. We had a number of people looking at this. It wasn't just Department of Health, it was actually included, for example, people, a representative from the National Care Forum, from other devolved authorities and scientists around, and we actually held a care summit as well to check that all of the data and all of the findings were tallying together, if you like. There were other studies, as Sir Wormald has said, relating to looking the other way, if you like, so trying to see what had happened in care homes and how many of those you could trace back. There was the Siren study, which of course is ongoing and provides ongoing information through the pandemic, and then Scottish and Welsh studies as well, and all of those studies point to, as community levels rise, the rates in care homes staff rise, and that appears to be the biggest ingress risk for care homes.
Okay.
So it doesn't say that there are no cases coming in from hospitals, and I think that's what the PHE study said, but it definitely suggests that those are by far the minimum number.
In terms of the data, and one of the things that jumps out is that if someone was tested having left a residential address but then moved to a care home afterwards, the test result would be registered to where they had lived rather than where they were going. That's just one example. Is there any other, you're in charge of a lot of this now, so what will you be doing differently to make sure that proper data is collected? Because it's a very serious issue, and it has, we saw very high rates of deaths in care homes, and lots of people bereaved, obviously, as a result.
But of course, actually, what we've seen in the second wave is a significant reduction in that, and that is where we've put in testing, both PCR and lateral flow device testing, for care staff on a regular basis coming in, and also prevented movement of staff between care homes, and that has had a very significant impact. So if you look back at the mortality rates in care home residents during the second wave, and particularly now, obviously with vaccination, we are in a completely different place to where we were in the first one. So I think, going back to your point, that the data is an important issue. It is both about the PHE piece of work actually was extremely difficult and very labour intensive in order to try and link that data, and I think there is a recognition going forward that all parts of the health service need to link that data.
Right, because that's really the point, that you're now going to be in control of a system that could sort this out, because the vaccine may help with this pandemic, but so you are going to be looking at this and making sure there's proper checking, testing and tracing, so that you can keep the data and look back and see where the problems are quickly.
Yes, so certainly this was about linkage between hospital data and residential care, and as you say, obviously patients or care home residents move very quickly. They won't all be in my remit, but there is definitely, and I'm sure we'll come to this, in the Health Security Agency, a real move to use data and analytics to
you just really slightly alarm me there saying it's not all in your remit. Which other bodies are involved?
So,
We're going to bring in Greg Clark in a moment as well.
Well, obviously it involves hospital data and general practice data, because residents move, and one of the problems you'll have seen with this was that an individual...
So that we know that on the ground. So who, though, in government, maybe it's Sir Chris, but who is responsible, if it's not all down to the UK Health Security Agency, who will be responsible for making sure that we don't have that gap if, God forbid, there's another outbreak or a future pandemic?
Well, on that. So, as you probably know, we've just actually published a new data strategy, which is aimed to bring this together. It is, as this committee is well aware, a complex picture, because the health service owns its own data, etc. So, what UKHSA will be doing is they should be the people who make sure that all of that adds together in a way that allows us to deal with pandemics better than in future. That's not the same as owning all the data, because obviously NHS data is used for lots of purposes and is
There'll be a controlling mind in your department.
Yeah, well, I mean, we look across the whole of health and care, as you know. We don't own all that data either, but it is our role to make sure that there is a framework in place so that UKHSA can do its job properly. Just on the general, on your point, I mean, I think you're completely right. I would say this situation, compared to the first wave, is completely transformed. I mean, data sharing has been one of the big advances we've made during the pandemic, and of course one of our challenges here was the creation of data in the first place and the very low levels of testing capacity compared to what we had now, as opposed to now. So on your lessons learned question, we are in a completely different place than we were at that point, and clearly one of the things we'll want to be doing is making sure we retain that capacity and that way of working going forward, whether we're in a pandemic or not.
Greg Clark, Chair of the Science Technology Committee, welcome.
Thank you, Chair. Thank you for having me here. As Sir Chris said, the Science and Technology Committee has taken interest in this report. We thought it's a somewhat strange report, I might say, from Public Health England. It came out without any fanfare and seemed not to focus on the key point, which is this: as we all know, there's a big question, and everyone's keen to get to the bottom of it, of how during the early weeks of the pandemic the discharges for hospital, whether or not they contributed to infections in care homes. And yet the report that was commissioned, until the chair asked her questions, gave a summary from the 30th of January to the 12th of October. In other words, long after this initial period, whereas the focus of interest is on those early weeks. And so we didn't understand why, in commissioning the report, it was decided to pool all of that data together. I don't know whether, Dr. Harris, you recall why that decision was
made. So
I
think I wasn't personally responsible for commissioning it. I certainly was in receipt of it as it came in for significant discussion, as you can imagine, in the care subgroup and for appropriate scientific discussion and challenge. I think actually part of the issue, as we've just described, is trying to get the right data sets in order to get sufficient numbers. And I think PHE, as far as I understand it now, have supplied a split of data for you, which broadly evidences the same thing in both the pre-period, if you like, the early one, and the later one. But it was simply, in many of these cases, just to get sufficient sample size to draw robust conclusions from them. And I'm sure that was all that they were doing at the time.
Who did commission it? So, Chris, did you commission it, or was it the former Secretary of State?
I'd have to go away and check exactly who commissioned it and who took that thing. But the idea was, as Jenny said, to get an overview of what was happening, not solely to answer the question that you're asking, but to understand how transmission happens in care homes. But as Jenny says, I think the data that you're after is available. And as far as I understand it, it doesn't show a different pattern, does it, Dr. Harris?
No.
But the problem was, and is this, is it not, that in order to identify someone that had COVID during that time, the period, say, from the end of January to the middle of April, the beginning of April, you needed to have a test. That was, in order to join the sample, as it were, you needed to have tested positive for COVID. But we know that there were hardly any tests being made at that time. In fact, during March, there were as little as 1,500 tests a day across the whole country, not much more than two per parliamentary constituency.
This goes to exactly the point that I started with. That clearly tells you something, because of course, if you went on to develop symptomatic COVID, then you were tested wherever you were, and you then, as Dr. Harris was describing, can track back where did that patient come from. So that's one part of it. But it's also why it's very important to look across the studies, as opposed to say, this study provides the answer. So as I understand the Scottish and Welsh studies, they were looking at the correlations between discharge patterns and other factors, i.e. regardless of testing. So look at where the outbreaks were, what were the common characteristics of the patients in those things, and they found, as I say, evidence that goes in the same direction as the PHE study. And this is why I started with the point that we should not over-focus on a single study here. What we have is a series of scientific investigations which between them give us the pattern that Dr. Harris described, and not to labour the point, not complete yet.
So my concern is that excessive weight might be placed on something where the impossibility of knowing who was coming into care homes with COVID was palpable, because there were not the number of tests available. But what
we do know is where were discharges made to and where were outbreaks, as it were. Now, and that is clearly, in the situation that you describe, extremely important evidence about what the relevant correlations were. Your point about let's not over-rely on a single methodology and a single study, I agree with 100%, which is why I started with the phrases.
The deployment of this study, including by the former Secretary of State when he appeared before our committee, actually placed great weight on this. And I just wonder whether, Dr. Harris, that it's important that we do shine a light on this, and it's difficult given the lack of data, but to draw the conclusion that the seeding from hospital is relatively small. That seems a little premature given this is one very methodologically constrained, if not suspect, way of proceeding.
The researchers who were doing this piece of work actually reported back on a regular basis to the social care working group. And actually the purpose of that group was actually to answer the question, where is infection coming from in care homes, with a completely open mind. And so this is, as Sir Wormald has said, this was just one piece of that. It was as robust as it could be. I'm very confident that the caveats around the data are written into the paper, and in fact the caveats go both ways, because somebody, for example, coming from hospital may actually have got their infection before. Somebody who then goes on to have an infection may actually get it from the care home, and it becomes extremely difficult without genomic studies to actually track this round. When we've looked at genomic studies, so there was some really good work in East Anglia, relatively small amounts, you've got quite a varied pattern. Most of them, the majority, were staff coming in and out, and then you could track the genetic family, if you like, of the virus. But you would see occasional ones coming in from hospital as well. But of course, if a patient has, for example, gone from residential care into hospital, then been discharged out again, and then become symptomatic and tested, they may actually have got their infection starting in the care home, not from the hospital. So I think the study, all the points you make are entirely valid, but they actually apply to the difficulties of translating this, particularly with elderly people who have very unusual and often absent symptomatology.
That's completely understood, and it's about the weight that's placed on the conclusions. Given, as Chris said, the importance of having different perspectives on it, peer review and the openness of data is very important. You'll know, Dr. Harris, from your work, how reproducibility of empirical analysis is very important. Sir Chris has been helpful in splitting the data out into the early phase and the later phase. Would you make available that data so that other researchers can make their own calculations based on it in the interests of transparency and getting to the bottom of this?
I'm very confident that the paper has been peer reviewed already, but it was actually peer reviewed in action, because many of the researchers working on this topic were in the social care working group, actually critiquing each other's documents and trying to draw those conclusions. So in fact the purpose of that group was to try and find information as early as possible, because of the significant morbidity that was affecting care homes, and pass that to ensure policy was developed as rapidly as possible. So every time a recommendation was made or a finding was there, it was having automatic scrutiny from some of the leading academics and researchers right across the country and right across the UK.
Well, that's very helpful to know, because we didn't get clarity on whether it had or not been peer reviewed. If you're able to supply the referees,
very happy to confirm that, but as I say, every article here, and in fact the other documents that were here, so the Scottish study and the Welsh study, because we had very helpful contributions from individuals in all of the UK countries, they would be contributing to the discussion and critiquing it at the time.
You will make the data set available for researchers to
it's obviously not my data set, but we can certainly provide, I'm sure PHE can provide whatever evidence.
There's a huge public interest, and there's nothing, I think I'm sure that
yeah, we'll go away and confirm exactly what is available and what isn't, and whether we ought to go further, yes.
I'm sure the Science and Technology Committee can see anything that's not public in secret, if necessary, private.
But as I say, do want to be crystal clear on this. We do not disagree with anything you have said, Mr. Clark, here. It is very important to look across the various studies here and to note that this is not a complete thing yet. And as you would expect, I chose my words very carefully at the beginning of this. All the studies we have point in the same direction. We don't have any pointing the other way. So we do think there is a significant point to be made here, but we recognise that is not the final story.
That's understood.
Okay. Great. Thank you very much, Mr. Clark. Nick Smith.
Thank you, Chair. Morning all. Mr. Wormald, further to our last session on PPE and your letter since, yes. I've got a couple of questions, please.
Yeah, I'm actually going to pass this to Mr. Maron, who is much more of an expert on PPE than I am and has appeared before you before. So I'll leave the answers to him if that's okay.
Of course. Sir, at the worst of the pandemic, between March and July 2020, the department was distributing some 500 million pieces of PPE, and that was great work. But from May to July, you ordered a further 28 billion items, enough for over 4 years. Why did you buy so much PPE then?
So we've bought in total 32 billion items of PPE. We have already supplied 11.7 billion to the front line, to health, social care, a few other uses. We currently expect to use another 11 over the course of the year. Essentially, we're providing about 1 billion items a month, the run. And of those billion a month, a sort of a significant portion now going through the PPE portal, which you remember now providing free PPE to social care, to GPs, to pharmacies, in a way that we weren't able to at the very beginning when we had an emergency service for those areas. So a significant increase in the amount going through. In terms of how much we bought overall, we were working on several assumptions, and our overall stance was to make sure we bought enough. You'll remember March, April, May, the pressure and the absolute importance of making sure that our staff were protected. So we looked at, with no really prior experience of how much PPE would be used in this kind of circumstance. So we had to build a theoretical model. The model was based on modelling how many interactions we felt there would be between patients and staff, both with COVID, so really important, particularly for things like FP3 respirator masks, only really used with COVID patients, but also general interactions with the public and staff, because as the guidance changed end of March, early April, we started to use PPE on a precautionary basis for any interaction between a member of the public and a health or a care worker. So a massive increase in the use of PPE, and not just based on cases, based really on activity in the NHS and social care. Our models for that, we, for COVID cases, we used the worst case assumptions that were around at that stage, and for how much activity in the NHS, we made assumptions on how quickly it would open up. I think as it turns out, our model was generous on the amount of activity that would be undertaken and therefore the amount of PPE. So our model probably overestimated. The second set of issues were really around, in those very difficult days, whilst we were purchasing and placing contracts, we were not certain that the contracts would come through. So, in March, April, May, into June and July, we simply weren't getting the orders through that we were expecting. And so we made additional purchases to cover what we expected to be a significant shortfall in order fulfillment, if you like. As it turned out, most of those orders came through late, as opposed to didn't come through at all, which has ended up with us having slightly more. Obviously, this puts us in a position where we have very significant stocks, which I think has allowed us to be really confident that we can meet the needs of health, of social care, and indeed provide PPE to open up the wider economy. Schools have had significant PPE for us to help in their opening up of the last periods. We've been able to help with transport. So I think a really strong position. It's not over yet, so we're looking at making sure that we can use our stocks. And in the areas where we do feel we have more than we're likely to use, we're looking at possibilities to sale, whether we can look at overseas donations, and for the bits of stock that are actually about 0.5, 0.8% of the stock that we have is not fit for any purpose, and we started to look at repurposing that. We've managed to recycle some of our out-of-date visors into food trays. So look, there's some interesting things we're doing to try and deal with the end, but I'd go back to the beginning. The purchasing decisions were really clear. The mission was to make sure we had enough, and if we took some conservative assumptions around what we would need, it was driven by the fact we did not want to run out.
Okay, thank you for that. Can you send us more detail later about your recycling visors into food trays? Of your long answer, that's the bit that caught my eye, I must admit. Coming on to contract.
Diversionary tactics there, Mr. Marin.
Yeah, it works.
But works. Mr. Smith's not going to be right to us.
Yeah,
Mr. Smith.
I'm a bit unsure about it. So, more information, please. So, I want to pick up this point about contracts. And in Mr. Wormel's letter, you probably kindly drafted it for him. Department outlined very high levels of PPE in stock, which you talked about.
Yeah.
But some of these contracts are still to be met and will likely involve hundreds of millions of pounds of what may be unnecessary expenditure, given, looking at the letter we were sent last week, some items you've got stocks that may last you up to 6 years. Yeah. How successful have you been in negotiating those contracts down? And can you quantify the financial downside or the risk if that's not possible? Because it's a lot of money.
Yeah. Okay, so look at to date, we have secured through either negotiated cancellations or variation in the contract, a reduction of PPE of around 1 billion items at a value of 475 million. So that's money we don't need to spend and PPE that we won't receive. We are in commercial discussions on a further 40 contracts to a value of 1.2 billion and relating to another 1.7 billion items. Now, those discussions are ongoing. Let's see where we get to at the end. I'm obviously happy to update the committee as we come to the end of those negotiations, but that's where we are currently, if that is a helpful update.
So pleased to hear that, but given what we know about the 30-odd billion items of PPE that were ordered in the end, that's a small percentage, and given the high cost of it, can we please, with your next update, have an assessment about the risk and the money that you hope to save, please?
Yes, of course.
Okay, thanks. Third question comes back to, given this large stock, and then you're going to be giving it away, and that's great, because I can think, of course, we all can, about the social care sector, and others might needing it in the future. But the nub is, won't it be very hard for domestic suppliers and manufacturers to maintain their business in this market, given that it's pretty much drowned with PPE that you've already got in stock?
So I think on the UK manufacturing, that sort of UK Make programme, I think has been one of our great successes. Of the 30 billion items, 2.5 billion are from UK manufacturers, and much of the material that's yet to arrive is, of course, the ongoing contracts with those manufacturers. So that's there. I think the thing that's often missed in the discussion about UK Make is actually the investments that companies have made in machinery, in plants, is allowing them to compete in the global market at a competitive price. This idea that the UK is always a high-cost environment is not true. Whilst it might be difficult in some of the really labour-intensive markets, gowns, for example, lots of hand sewing, where it comes to things like masks, visors, aprons, much more likely that we can meet a competitive global price. So we're seeing negotiations of where price can go looking that way, and indeed some of our firms successfully selling their products into other markets already. So we'll continue to work with the UK Make on how do we ensure resilience, and as part of the long-term strategy for PPE, we do want to see a more resilient supply with greater UK manufacturing capability. We all saw, again, back in March, April, the difficulties of securing internationally and the value of having that UK resilience. So I think we're confident we can keep that going. You are right that whilst there are very large volumes of PPE currently manufactured, and other countries also have significant PPE, we will need to work through how do we ensure that the investments in the UK continue to work. And part of that will be bringing together the NHS demand in the work that we're taking to say what's the future of the NHS supply chain, and how do we ensure that we have a better conversation with the NHS about what it needs overall, and then how do we procure that, and whether that can be helpful in securing UK manufacturing.
Just one question, please, Chair. Don't you expect other countries that had a PP shortfall to produce their own domestic supplies as well, though? And doesn't that mean that it'll be hard for our suppliers to sell their PPE around the globe too?
So I think it's certainly could be the case that there is an excess supply of PPE. But let's see. I mean, this pandemic is a long way from over, and so I'm sort of slightly cautious on.
Okay. Yeah, I think that's
we used it all.
That note of caution is, I think, very welcome. Can I just ask we had some witnesses in from PPE suppliers. They were very clear that their focus was on high-end PPE, not manufacturing the mass stuff because they couldn't compete on price. But you've just said they can compete on price. So just can you tell me specifically, how many companies, which companies, just some more further information about who is actually able to provide this cheaply in the UK?
I'm happy to come back with very detailed, but certainly the work we've done with companies manufacturing masks, some of the other products, I mean, generally it's capital investment. And once you have your machines, then the actual costs of manufacturing here are no greater than in other countries. So we think that we have firms that are well placed to compete. I'll happily come back with the details of the individuals. We've worked with over 30, and in
if you could, because we and other committees may want to pursue this, because it's just we're getting very different messages. Obviously, there's only a subset of people we had as witnesses. We can't speak to everybody, but that was just it jarred a bit. And the other thing was, you mentioned,
if they're gown manufacturers, then I would understand that is one area where it's very difficult to compete in the UK.
So when it's basic sewing, it's more expensive here. Is that
very
saying, right?
And the other area is gloves, where there just isn't the infrastructure here. So that would require a significant investment to bring gloves manufacturing, which, as you know, is largely in Malaysia.
Yeah, well, I think we picked up on the gloves one before. Can I just ask as well, you talked about, in answer to Mr Smith, the amount of PPE that you think might not be ever usable, whether it's converted into food trays or whatever. Do you have a forecast or an estimate about what the final level of unusable medical PPE will be from what you've commissioned?
So we're still working through. So as you know, we've taken the sort of quality assurance process really, really seriously. And the way we've done that is, as the materials have come in, we've had a sort of a first pass, and anything we've been not confident of, we've just held. So you'll have seen that with the materials we've provided you in Chris's letter and others, that the numbers in that do not supply stock are coming down as we are able to go back through look for whether we have the right certification testing to allow us to do them. So, for example, a significant block of masks, we have now managed to pass them for. There was a concern about whether what's the right word? Whether they might react with skin. So just the actual, their biosensitivity testing, we didn't have confidence we had all the paperwork when we did the first pass. We've now got that agreed by the manufacturers and the regulators. So those have been released.
Right. So you're going through a rigorous process. So when do you think you will know?
We're down to about 1.3 billion that we're still looking at. Yeah. And over the next few months, we will be able to be absolutely clear of those. Okay. Of that 1.3, that's not used in the NHS. And that there's quite a broad set of categories there. So, for example, there'll be things that essentially the NHS don't want to use. So, aprons. We have aprons in boxes, perfectly legitimate, meet all the standards. The NHS don't like them in boxes, they like them on rolls because it's how they use them in the wards. So some of the products that are not for the NHS, it's not that there's any kind of problem with the standards of the product, it's just not what they use. Gloves, the NHS prefers nitrile, we've got latex gloves. So that's one set of things. Then we've got some others where actually they were bought, for example, we have surgical gowns which were bought, which obviously need to be sterile. So we have some others that are not sterile, but could be used as isolation gowns. So some of it is about actually there's a different use from what's bought. Okay. So it's working through each of those.
Right. Well, so when will you have got work through this? When will you have an idea of what's used? And I'm trying to categorise it. Some could be used in medical settings.
Well, look, we're continuing through. We're now through the main bulk of new stock coming in. Yeah. So we are accelerating our way through the existing stock. So I think over the next coming months we will have.
Next coming months, by the end of the year, by the end of the summer. Give us a stab, Mr.
We'll certainly update you by the end of the summer, and then let's see where we are then.
Thank you. We're keen to learn that. Right, we now need to move on to the main discussion today after that, but that's very important to get to the bottom of those issues, particularly around care homes, discharges, which I know will be a long subject of discussion as we go forward. But we want to now move on to test and trace. And I just want to get some facts straight first, Baroness Harding, about your role and when it began and ended. As we understand it, you left on the 20th of April this year. Is that right?
Not quite.
Okay, right. Perhaps you could just update us on your dates then.
Thank you. And I thought I'd just also ought to start by just correcting something you said in the introduction, because I wasn't the accounting officer as a non-civil servant. So the accounting officer for the vast majority of the time I was executive chair of NHS Test and Trace was David Williams, the second permanent secretary, and then towards the end Shona Dunn, who's at the hearing. So just to be clear that as there's obviously
day to day you were watching the budget and handling.
I'm absolutely comfortable taking responsibility for the leadership of the organisation, but as we know, there's a specific technical term of being accounting officer. So the Prime Minister called and asked me to take on the role on the 7th of May 2020, and coincidentally at my last day at NHS Test and Trace was the 7th of May this year. Dr. Harries started at the beginning of April of this year, and we spent the month of April in a very managed, coordinated handover.
Okay, so your responsibility completely finished on the 7th of May.
That's okay.
But you, in the meantime, so Dr. Harries was responsible. Who was the responsible owner of this from during April then?
So operationally, I
You
was
still were.
responsible. Clinically, Dr. Harries took increasing ownership of particularly, for example, the management of the Delta variant, and Shona Dunn was the accounting officer throughout.
Fine. Okay, thank you. So that's very helpful, and thank you for the correction. So I'm going to ask Barry Gardner, MP, to kick off on this issue. Mr. Gardner, online.
Thank you, Chair. And Baroness Harding, let me share a secret with you. The Chair has said to me that I must be nice to you at the beginning. So I think that means that she's got some really nasty questions lined up for you later on. In the year that you were the Chief Executive, there were 2 national lockdowns and more than 4 million confirmed cases. Given that Test and Trace was supposed to break the chain of transmission to get life back to normal, those figures don't really spell success. So my gentle question to you is, do you think you were given an unrealistic brief at the beginning to break that chain of transmission and get life back to normal?
Well, firstly, thank you for being nice. And thank you, Chair, actually, for your kind words at the beginning of the introduction. Maybe if I could just start to sort of, in answering your question, Mr. Gardner, just to put some context. So the purpose and objective of NHS Test and Trace was to help break the chains of transmission as part of the overall COVID response. It was one, not the only tool that the government set out as its response to COVID. So, the non-pharmaceutical interventions, the restrictions, the MPIs that we have all had to live through, the first element. Obviously, NHS Test and Trace, the second. The third, the vaccine programme, and the fourth, the therapeutic treatments to help people cope with COVID better. So NHS Test and Trace was never set up to be the single solution to COVID. So I think it's important that we start with that context. So then, secondly, as the National Audit Office report sets out, and I say this with some trepidation because just as the discussion that the committee's just had about infections in care homes, the science is still evolving as we learn exactly how to evaluate all these different programmes. But as the NAO report sets out, the evaluations that exist to date suggest that NHS Test and Trace had a material impact in reducing the rate of infection. So the work quoted by the NAO, there are a number of different scientific groups that have been trying to model the impact of the order of 18 to 33% reduction in the infection rate due to testing, tracing and isolation. Appreciate that's a very wide range, and as the report rightly points out, there are lots of assumptions and there is a lot of ongoing work around the world to evaluate the effectiveness of these sorts of interventions. But I would actually argue, and I do appreciate that a lot of people listening to this might find this rather incredulous given some of the way it's been reported, but I would actually argue that NHS Test and Trace has been a success, that it has delivered on the objective to help break the chains of transmission as set out in the NAO report.
Well, I refer you back to the 2 national lockdowns and the more than 4 million confirmed cases. And if you think that Test and Trace has been a success,
Mr. Gardner, could you just lean into your microphone a bit, please? We're hearing you
certainly,
in the
of
room.
course. Given the 2 national lockdowns and the 4 million plus confirmed cases, you've correctly identified that Test and Trace was not on its own in seeking to break the chain of transmission, but that means that other areas you would have to say have failed in their objective if you are not allowing that there was any failure on Test and Trace. So I'm not sure whether you're trying to shunt the blame off somewhere else by saying, well, we were only part of the picture and we've been successful. But let's look at exactly your particular.
Sorry, Mr. Gardner.
Mr. Gardner, can I bring in Sir Chris Wilmot?
Yes, I think I need to come in on this point. I mean, Baroness Harding described this absolutely correctly. The government effectively has 4 pieces of weaponry with which it fights COVID, one of which is NPIs, including lockdowns. and we deploy test and trace and contain vaccines, therapeutics, and lockdowns, and that is basically what we use to control the disease. Now, where you are completely right is the balance of how we use those four things in conjunction has changed over the course of the pandemic, and what we are seeking to do, as you know, is move away from reliance on legal NPIs and move much more towards at the moment vaccines, and hopefully in conjunction with vaccines going forward, improved treatments and therapeutics. So I don't think it's possible to say there is this specific role for test and trace. It has evolved over the pandemic, and the important thing is how how those four things interact. So of course we've used MPIs, we've used them from the beginning, and at times we have used them more intensively in response to how the disease was reacting at this point. That's a separate question from the effectiveness of test and trace within those four, and it's certainly not blame shunting to say that we use all four of those and we use them in different combinations as we
of course, it's not blame shunting, you're absolutely right. But there are 130,000 people who have died, and if Baroness Harding is saying that test and trace has been a success, then it implies that the failure is elsewhere. So let's focus on test and trace. For the tests to be effective in breaking the cycle, it's best that there be no more than 48 hours between identifying an index case and their contact self-isolating. But my understanding is that you haven't always operated to that target. Do you agree with the NEO that you need to speed up the process, including how quickly people actually book their tests once they notice symptoms?
I absolutely agree that speed is hugely important, and as the NAO report sets out, over the course of the last year, we've learnt a lot, and we've got a lot better at turning around tests and contact tracing end to end. I may defer in a second to Dr. Harries to describe the sort of clinical logic for why it's not a binary 1-0 thing of a certain date or turnaround time is good and anything beyond it is bad. Actually, the faster the system works, the better. The sooner we isolate if we are infectious or at risk of infection, the better. Now, the sage advice that we have worked to throughout has been clarified since I last appeared before the committee to confirm that their operational target they set us was that to go from test booking to contacts reached within a 48 to 72 hour turnaround. And on in-person tests, we have been hitting the 72-hour target since January, and actually because we were hitting it, we increased the target to make it harder to drive further performance improvement to 48 hours, which we hit in March of this year. That's not to say that we can't continually keep improving or that it's something that the team has to keep working on.
I'll come back to those in-person tests in a moment. But my question was, do you agree with the NAO that you need to speed up the process of how quickly people actually book their tests once they see symptoms? That was my question.
Okay, I'm sorry, I misunderstood.
About how you're encouraging people the moment they feel symptoms to get the test.
Yeah. I mean, I agree that it's important that we encourage people and we work on the whole process end to end. I also agree with your statement that as we stand today, the single biggest opportunity to continue to improve performance is people coming forward if they have mild symptoms and getting a test, and making sure that then the process kicks off as fast as it possibly can.
So what improvements have you made in that area?
Yeah,
and how are you taking that forward to encourage the public, the moment they're symptomatic, to get the test?
Yes. Well, obviously, I finished in NHS Test and Trace 2 months ago, so I can talk up until May, and
Sure.
then Dr. Harries can talk for what's live now. But if you look back through the course of the last 9 months, we've substantially expanded the number of testing sites to make it ever easier for people to get a test. So over 1,000 face-to-face testing sites for symptomatic tests and a further 1,000 for asymptomatic testing. We've worked with partners throughout the end-to-end journey to make it easier. So, for example, for home tests, the Royal Mail now picks up from priority post boxes on a Sunday, and that's the first time they've done that for over 100 years. So we've worked with partners to make it easier and easier, whether you're face-to-face or doing your test at home, to access it. We've done a huge amount of work with local authorities and community groups and voluntary organisations to make testing accessible for people for whom English isn't their first language. So if you call 119, there are over 200 languages spoken. The test kits come in a variety of different languages, in Braille, using British Sign Language. So we've made a huge amount of changes through the course of the last 12 months to make the system more accessible and also to communicate and explain to people why, as I say, even if you only have mild symptoms, you should come forward. But I'm 2 months out of date. So
yeah, sure. Look, before we move on, you've given me a number of things that you've done. What I would ask is, how did you quantify how quickly people were coming forward once symptomatic, and how that has changed as a result of all of those things that you've done? Have you been able to say, this is where we were at a baseline, this is what we did, and as a result of what we did, we now know that people who are symptomatic are actually booking their test more quickly and notifying us?
Yeah, you hit upon something that is very hard to fully quantify, because the only way really of being able to tell whether people are coming forward when they should is based on what they tell us. So we run a series of surveys, increasing surveys with the ONS to understand whether people are coming forward or not. And again, I'm sorry, I'm not trying to be evasive. I'm genuinely 2 months out of date, and so important that you get the up-to-date view from Dr. Harries.
Dr. Harries, indeed.
If I could just, I mean, there is an important point actually which overrides all of this, which is 1/3 of cases will be asymptomatic. So for those individuals, actually this is where the lateral flow comes in and asymptomatic testing. It's important because we are picking those up and they would not be coming forward because they will not have symptoms. So I think that's an important point. For the other 2/3 of the cases, exactly as Baroness Harding has just said, it is possible on retrospective surveys to ask individuals, but for many people in this room, I know, self-reported surveys, particularly if they are post hoc, as in people are remembering back to where they first got them, are quite unreliable in some ways, because individuals will, I mean, speaking on personal experience, I had anosmia. I know when I became anosmic, but for many people that is not the situation.
Just I think we know what anosmic means, but do you want to just explain?
Sorry, when you get a loss of taste or smell. But for most people, actually, that is not their experience, where they can say precisely at which time and on which day they did it. And in fact, once they have symptoms, or once they have a positive test, their historic memory of when their symptoms started is quite challenging. So there is data. There are both opportunities through the recording, through contact tracing, but equally, I think probably more importantly, there are robust scientific studies focusing on individuals, trying to look at that. But it is a very, very complex picture, and I think it's quite difficult. I think the answer to your question actually is that the contribution, as Baroness Harding has said, to national communications, and I would argue a really important one, is the increased engagement with local authorities, with directors of public health, who actually know their communities and who will know how, and how to focus messaging in a trusted way, because I think this is not simply about communication, it's about trust in the system. And what we can definitely demonstrate, I think, from Baroness Harding's time and my own as well, is actually moving forward, liaising with local authorities and getting those messages through trusted leaders is often
indeed,
good
Dr.
work.
Harrison, that's what many MPs were actually saying at the beginning of the process, when that message was not implemented in the way it has subsequently been. But look, I want to pick up on what Baroness Harding was saying about in-person tests, because my understanding is you don't have a target for end-to-end timeliness of home tests and tests in care homes, which are actually the majority of the PCR tests, aren't they?
Well, actually we do, and we do monitor it just as closely. So the time frames I described for in-person tests, if I give you the, for all tests, by mid-January, 73% of all tests were, from test through to contact identification, 73% were completed within 48 hours and 91% were completed within 72 hours. So we do monitor it. You are absolutely right that there is more work to do on home testing. It's one of the reasons why I point to the work we've done with the Royal Mail, who have been excellent partners in making it ever easier for people who can't get to a physical test site to get their home test back quickly and turned round. But I wouldn't want you to think that we don't take home testing turnaround time seriously. We really do. I would say, though, that the substantial majority of positive test results do actually come through the in-person channel. And that's because home testing is used for asymptomatic testing in care homes. So there are far fewer positive tests that come through that, and also used for our borders testing programme and quarantine programme. Again, a lower percentage positivity. So there is a logic for wanting to make sure that the in-person is absolutely hitting the targets.
Thank you. Initially, I believe you estimated that there would be about 15 to 20 contacts from each person who tested positive. But actually, people only told you about 3 or 4 contacts, didn't they? And that's basically their household members. Is it that people were embarrassed and didn't want to lose their friends by identifying them? And how have you sought to overcome that problem?
I'll answer that in just a second. I just realised I've given you the wrong numbers. I'm very sorry. I gave you the in-person percentages, just for the record.
Yes, please.
The all PCR within 72 hours is 75%, and within 48 hours, is 54%. But apologies for confusing the committee. In terms of the number of contacts, you're absolutely correct that when I arrived last May, the SAGE modelling upon which the government had decided to scale contact tracing was based on the assumption that in ordinary life you would have circa 30 contacts, close contacts, as you go about your business. And that was one of the reasons why the contact tracing system was scaled to the level that it was during last May. And what we found from the very beginning of the launch of NHS Test and Trace was that coming out of lockdown, actually we weren't living in normal times and people weren't having that number of close contacts. And they were also, I think and suspect, heeding all of the clinical advice not to get within 2 metres of people who were not their close family that they were living with. And so we did see, and have continued to see, a much lower number, as you say. Dr. Harries will have the up-to-date numbers, but much lower number of close contacts, in part because of the other interventions in the government's approach to fighting COVID. What we do see from the NHS COVID-19 app is that the app is able to identify contacts that you don't know you had. And so we do see more close contacts identified through the app, through digital contact tracing, than through individuals reporting their own close contacts.
Only a minority of people who develop symptoms request a test. In fact, the NA report suggests that older people, men, and poorer income groups do not request a test, even though they recognize that they have symptoms. So is it fair to say that Test and Trace is operating fairly well for wealthier, middle-class, white women but not really terribly well for anybody else.
Well, I think that you hit upon one of the most important learnings from the course of the last 12 months, which is that COVID-19 is an incredibly unfair and unequal disease. And I know that Dr. Harries and all her colleagues in public health would say this is true of almost all infectious diseases, that they disproportionately affect the most vulnerable in society. And I think it's probably one of the most important learnings for us as a country as we look back on the last year is how we target and tailor these services to genuinely work for the people who most need it. And Dr. Harries has referenced how important it is that we work closely with local authorities. As you know, that was one of the big priorities of the Test and Trace business plan published in December. So one of the first things I did personally last May was appoint Tom Reardon, the Chief Executive of Leeds City Council, to my leadership team so that we could really work closely with local authorities. And I think, you know, with the benefit of hindsight being a truly wonderful thing, you look back and say, you know, last May, the government strategy and indeed the WHO strategy as well was to build scale. You know, we were told to test, to build scale. And over the course of the year, we've got better and better at supporting the most vulnerable and targeting our testing services towards them.
Baroness Harding, sorry. With the benefit of hindsight, of course, that's right. But many people were saying this at the time in Parliament. But I don't want to refight that battle, okay? What I want you to focus your answer on is how now the test and trace system can reach those people that the statistics in the NEO report show are not being reached.
Yeah.
The elderly, men, poor income groups. Well, that's the challenge. It's a challenge that still faces the system, the test and trace system. And it's really critical that if we're going to have a system that is fit, not just for, let's hope, the end of this pandemic, but for future pandemics, then we need to get over that challenge.
Well, I would completely agree with you. It's why the NHS Test and Trace business plan put working collaboratively in a team of teams with local authorities as the #1 priority in December. And it is an ongoing programme of work. I think in terms of, as you rightly phrased the question, how do we continue to get better now? I do think Dr. Harries is better placed to answer for now.
Certainly.
Yeah, shall I contribute to that? So I think number one, we need to understand the data. So we need to know who it is we need to reach. And that data is really, really good now. So we look routinely both at the data which comes through from Test and Trace. It goes through the Joint Biosecurity Centre. It's evaluated as well with Public Health England. And we look at, for example, cuts by age group, by ethnicity, by working group, which by locality. And match up the testing data and particularly the immunisation data as well, because often it is the communities who are also not coming forward, or the particular groups not coming forward for vaccination, who are also not coming forward for testing. And I think picking up some of the learning, which Baroness Harding has described, in some of the areas which we may go on to in the future, where we have looked at surge testing, for example, in different communities, actually putting the NHS and Test and Trace working alongside with Directors of Public Health and pushing out those groups together has been very, very successful, as I've said previously, working with local leaders, whether it be local council leaders or particularly local faith leaders, for example. There is some difference in data, though, because there was actually another study which actually showed women were not coming forward, so it does vary, and that's why the geography, the age group, it will vary in but all of these different variables. So having the granularity of the data is really important, and I think that is an area too which has improved dramatically as we've gone forward, and will continue to under the Health Security Agency.
And of course, those demographics may actually cross in effect, so that the reason that women are not coming forward in some communities may well be because they're ethnic communities where that's not done in the same way.
Exactly. There was actually an ethnicity study which was again in one of the SAGE subgroups by Professor Kamlesh Kunti, who highlighted that in some ethnic minority groups of Indian heritage, women actually were more affected. So absolutely right, it needs the granularity of the understanding of the communities.
So are you confident that you now have established the baselines for those underrepresented groups, and that you have targeted operations that are locally targeted, specifically targeted demographically and geographically, to actually change those baselines and bring them up to what you would like to see as the target average?
Yes, I mean, there will clearly always be more we can do, and we will continue to do that. But I think there have been a number of very specific interventions, again, as Baroness Harding has said, in both, it's not just the written language, but in communications. It's who you're communicating with, it's how you're putting out your services in a sensitive way, and actually also just practical things for example, for disabled access for testing. If people feel they can't get to a test site and it doesn't work for them, that will soon spread and people won't go. And so we know we have net promoter scores, for example, and there's no difference in the scores between those who need disability access and those who don't. So I think we are monitoring a lot of these areas, far more than we could ever have done to start with, and we'll continue to.
And finally, could I ask you to send to the committee a range of baselines that you're focused upon, so that you can tell us in a few months' time exactly the changes that have taken place in those numbers, and the committee is able therefore to monitor it properly?
Very happy to, just with a slight caveat at the start, which of course is we'll flow through all of this. The pandemic is changing hugely as we go forward, and so the combination of rising and hopefully then falling rates and vaccination will mean some of that data, before you've even got it, we will send it, may be quite difficult to interpret.
Well, we're going to be touching on the future, of course, later, but thank you very much, Mr. Gardner, for now. Now we're going to turn to Sarah Olney MP online. Ms. Olney.
Thank you very much, Chair. Baroness Harding, at your previous appearance before this committee, we talked a bit about the importance of self-isolation once contacts had been traced. And you said on that occasion that was sort of beyond the remit of test and trace in order to kind of enforce the self-isolation or come up with the policies to encourage self-isolation. I wonder what progress has been made, to your knowledge, in other parts of government to improve self-isolation rates since then?
I can answer briefly, but one of the things that has changed since I appeared before you last is that Jonathan Maron is the cross-government senior responsible officer for self-isolation. So really I should pass most of that on to Jonathan.
Mr. Maron, thank you. Mr. Maron.
Hello, sorry, just coming off mute. So look, I think we've really significant work on trying to improve self-isolation. I think the first thing I'd say is the monitoring that the ONS are doing now of self-isolation amongst positive cases is really strong. We're seeing over 80%, 86% in the latest data of people saying that they fully meet the self-isolation requirements, and of contacts even higher, 93% of the latest reported. So isolation of people who've had a test or have been contacted by test and trace is really quite good indeed. Mr. Gardner raised the wider data of people with symptoms, 43% coming forward to have tests. So there's, as Baroness Harding has spoke about, trying to tackle that has been a major part of what we might do. I would just add to Baroness Harding's answer, of the people not coming forward, about 40% of them are essentially dismissing their symptoms. They don't think they're ill enough or they get better. So the message that Jennie was giving around make sure our communications are really clear about when to have a test is really important and will continue to be important. So in terms of trying to tackle improving isolation, three things that we've really tried to think about. One, the communications, making sure that people still realise it's important to get a test when they have symptoms. And I think that will continue to be an important part of our overall strategy. And again, as Jennie and Dido have both talked about, getting that down to how do we work with local authorities to get targeted messages to particular communities is a really important part of doing this. You can't do all of it just from the sort of national headline messages. So that's part one. Making sure that it's easy to get a test, so the physical barriers are removed. Again, Dido spoke about it, over 1,000 sites, 35,000 post boxes, home testing, pharmacies being able to give kits. We've really tried very hard that there isn't a physical barrier. So it's not that you can't get a test. And again, we had some comments.
Mr. Maron, sorry to interrupt. Just
I've got one more that I want to talk about. And then the final bit, I think we try to work on, are there barriers to self-isolation? What is it that stops people? Which I think is the bit that then you can be most specific, where we've gone for 3 significant things. One, we've made really significant sums of money available to local government to pay support payments to people who need to self-isolate. So that comes in 2 parts. The overall scheme, we've made £176 million available. The first 73 million of that is for the main national scheme, the test and trace support payment, which pays £500 to anybody who needs to self-isolate who's on a set of qualifying benefits. So, people who are most at need. Given we've always understood that actually there are some people who face hardship but don't quite meet those criteria, we've made another £75 million available to local government to allow them to make discretionary payments to people facing hardship. So really significant sums of money now going into local authorities to help them pay £500 payments so that people can afford to self-isolate. So that real concern that are people not isolating simply because they can't afford to, we've worked really hard to address. Obviously, that's a burden for local government to do it. It's a lot of work. So we've made £28 million available to local government actually just so they can run the scheme. So that we're trying to make sure we've taken that as well. And then on practical support, from March, we've been running 2 schemes. One, a medicines scheme, so that if you need to get medicines while you're self-isolating and can't get, a friend, a family member to do it for you, you can now contact your pharmacy and they can find a volunteer or get somebody to you. That's £32 million a month. And we've provided £12.9 million a month to local government to fund practical support. And we've been working with a range of local government colleagues, particularly about 20 local authorities, been very active in helping us in trying to just define what's good practice in practical support, where again, clearly, knowledge of your community on the ground, working out how to do that is the most important bit. And then finally, because that's available everywhere, we've got a set of pilots now, another £12 million to fund a range of pilots trying to look at what could we do further, and really in 4 blocks. I've got some local authorities looking at intensive support. Do you need to buddy people up? What is it that some people need to really ensure self-isolation? We've got some pilots around crowded accommodation. Is it actually, it's hard to isolate because some people live in very crowded accommodation. A pilot working on the awareness of the need to isolate, which again, I think comes back to some of Mr. Gardner's questions earlier, how are we getting those messages across? And a further set of pilots, a couple of pilots looking at speed, other things we can do that really speed up those initial sets. So I think it's, if we look at what we've done over the course of the pandemic and how we've learned, we've put in place really substantial funds to all local authorities to make payments available for people on qualifying benefits, further funds for hardship payments at the local authority's discretion, and then a set of practical support. And now really trying to learn from a set of pilots on, are there more things that will drive a substantial increase in uptake of both testing and isolation?
Thank you very much, Mr. Maron. I wonder, did the funds that you're talking about, did they come out of the test and trace budget, or did you have to lobby the Treasury for additional funds?
The funds are agreed with the Treasury and they've come out of the test and trace budget.
Thank you very much. I'm going to move on now to the new variant, and I think this might be a question for Dr. Harries. So the new variant, the Delta variant, it obviously been in the country since about April. My understanding is it now accounts for 99% of all positive cases of COVID that are currently being reported. I wonder, Dr. Harries, how do you, we've talked earlier as well about the genomic work, and that obviously helped us to identify and track the Delta variant quickly, but why has test and trace not been more successful at stopping the Delta variant from spreading?
So I might start outside the UK actually, because if we look across Europe at the moment, even to places where we often quote as being highly successful, for example Singapore, they also have a problem with the Delta variant, and I would forecast fairly robustly, I think, that over the next 4 to 6 weeks we will see this variant cause huge problems across Europe. You can see them just starting to tick up now. So I think one of the issues is it is highly transmissible. It is more transmissible than the Alpha variant, and we saw a similar pattern, if you remember, that was the cause of our second wave with a very sharp rise. That one, you're quite right, we didn't have, that was the start, if you like, of understanding the importance of very early genomic detection. And we've gone on since then to develop reflex assays, which are a sort of very general way of switching in testing to enable us to see which variants are causing the problem across the UK without necessarily having to wait for the detailed genomic testing to come back. So we have really good detection mechanisms now, and we are, as you say, probably leading the world. I think in relation to this particular variant, it's difficult. If you look at the South African one, for example, we've been highly successful. We had quite a number of pockets of the South African variant which were brought into the country, and they have been stifled. Lots of great work with local authorities, with test and trace. There are still a few cases around, and we continue to monitor them, but it hasn't turned into the sort of wave that we've seen with Delta variant. So I think transmissibility is a really important one. And there were some successes in controlling Delta as well, actually. The one I tend to refer to is Sefton, where we saw quite a sharp rise and then a fall. Bolton we often refer to as well, where there was really brilliant work. I went there myself and saw local authorities, local teams working on that, and certainly that has come up and come down more quickly, but it hasn't been containable right across the country.
But with the benefit of hindsight, once we knew that the Delta variant was in the country and we knew, I assume quite early on, that it was more transmissible, is there anything we could have done differently via the test and trace programme to have stopped it spreading quite as quickly as it did?
So I think my point of referring to other countries is because I think it's extremely difficult to do. I think we did have some successes. One of the difficulties with variants is, and we talk about variants of concern and variants under investigation, is because there are thousands of mutations ongoing. So I think there have been more than 4,000 mutations of this virus, and it will continue to do that. We hope it will settle down in due course. And so trying to work out which ones are of significance or not is quite difficult. If a mutation signals that it has some sort of characteristic in the mutations which we think might signal a problem, might be linked to other cases with higher transmissibility, or might be indicate it could be a vaccine escapee, then those ones we will be watching under investigation. But it takes some time between to enable us to understand whether it is actually more transmissible. For you have to it's almost as if by the time you've got there, it doesn't matter whether it was the UK or anywhere else, you need a significant number of cases to be able to be absolutely definitively sure what the clinical characteristics are and transmissibility of the variant. And it's one of the huge challenges of managing this, because if every time we had a mutation we shut everything down, society would stop. Obviously we'd have done it 4,000 plus times, just not realistic. And so there is a gradated way, if you like, of trying to manage this through variants under investigation and variants of concern. And it is UK data which is often informing the rest of the world now. So 40% of the GISAID uploads show of the genomic sequencing globally is from the UK. So I think we did have some successes in many places, and some of those I've highlighted. We had enhanced response areas where we worked absolutely alongside local authorities. We had the armed forces actually helping with the logistics. We had worked with local communities, and it has had success, but the transmissibility is quite difficult to control.
Thanks very much. I just, we know that restrictions are going to be lifted on July the 19th, but we're not stopping the requirement for people to self-isolate when they're pinged by the app. This is causing some concern amongst the business community and in the NHS, because if we've still got very wide or rising cases, there's a big risk that people will be pinged and have to self-isolate, and the NHS in particular I think are concerned on the impact on their workforce. They'll have lots of their staff having to self-isolate instead of being at work. What can the test and trace programme do to try and address some of these workforce concerns?
So just as a starting point, two things. Number one, the decision will be made on the 12th, not yet. I realise that might sound a technicality, but it's very important given that the data is changing quite rapidly at the moment. So that's number one. And secondly, we still need to remember that if you are pinged or if you are a contact, you are at higher risk, even if you are double vaccinated, of becoming a case if you're a close contact of somebody. So this is there for a purpose, not for annoyance. It's a public health management thing. But as the population becomes more vaccinated and we know that there's a significant improvement in reduction in risk for those, particularly the elderly, of serious illness, hospitalisations and deaths, then obviously that move to reduce self-isolation is appropriate to get society back again. In relation to the health workforce, we have a piece of work actively ongoing with that, with other senior clinicians across the UK, because you'll appreciate the clinical workforce, and I'd include the care workforce in that as well, for care homes, for reasons that we've said. It's really important that where you have high rates of infection, society may be getting on otherwise outside, or it may be mostly in younger people, but hospitals will have people coming in who are infected. So really important that we look at that particular element really carefully. And then on the app, we are actively, again, have a piece of work ongoing at the moment, because it's entirely possible to tune the app to ensure that it's appropriate, if you like, to the risk. And of course, when the app came into action, and that was Baroness Harding's efforts at the start of that, we know it's been hugely successful, but it's been utilised in a world where we did not have vaccinations. So actually working through what a vaccinated population using the app means is something that we're actively doing at the moment.
Yeah, and if I may just come in on that, because the two sides of your question there exactly demonstrate why the judgments in these areas are so difficult. Looked at from the perspective of variance, of course, you dial up all these various measures, as Dr. Harris was describing, and the equal and opposite desire that everyone understands to reopen society and diminish some of the other detrimental impacts of our MPIs push you in the opposite direction. And these are the decisions that government and ministers have to take here, and there isn't an algorithm that tells you how to do it. So, and this is what Professor Whitty was describing at the press conference earlier. These are exceptionally difficult judgments where we have to, as it were, balance up exactly the concerns raised in your types, in the two halves of your question, and come to what we think is the greatest public interest approach. But I think we all should recognise that that will always push in two directions, depending on whether your question is how do we control the Delta variant, or your question is how do we minimise the disruption to people's lives and their wider health and the economy.
Okay.
Thank you very much. Back to you, Chair.
Thank you very much, Ms Olney. I now want to turn to the money. So I'm going to turn to Baroness Harding first as the person who was responsible for the money, but also Shona Dunn, stand by, because obviously as you were the accounting officer, and then I'll come to Dr. Harries in a moment. But if we look at figure 6 on page 33 in part 2 of the NEO report, lays out a very clear table, Baroness Harding, which I think gives me the basis for trying to understand what's happened. Because in November of last year, you, as the executive chair, led the bid to the Treasury for extra money to increase your budget from 10 billion for the financial year to 22 billion. And in January of this year, when we had evidence, that expectation was that the spending would reach 21 billion by the end of the financial year. And yet we've seen a significant underspend, 39% underspend. So first of all, could you just give me the headlines on why you think that is? And then I want to go through some of the detail in this figure about why money hasn't been spent as expected.
Of course. So there are three main reasons for the underspend. The first one, which accounts for circa £4.3 billion, is costs avoided because of activities that were cancelled as a result of the country going into the lockdown at the beginning of the year. The second main area is for £1.7 billion, activities that were moved from the financial year 2021 into 21-22, so delayed because of the decision to go into lockdown. And then the third large bucket is £2.2 billion, which were commercial savings, where we were able to negotiate either lower rates or stop doing non-value-added work with various partners.
Okay, I mean, but it's a significant shift. So while it is an unpredictable, there are elements of this that are unpredictable. Let's just go through the table here. So testing obviously takes up the bulk of the budget for test and trace, as now part of the UK Health Security Agency. I'm puzzled, though, for example, why Pillar 1, the NHS swab, why the budget was nearly 50% less than that case. I mean, that's a significant shift downwards. What happened there? What happened? Why was NHS swabbing reduced so much?
As you say, the vast majority of the budget for NHS test and trace is testing. 70 to 80%. And testing is a volume variable activity. So the cost is highly correlated with the number of tests, which in turn is a function of what's happening with both the disease and government policy.
Okay,
so we saw the country go into lockdown and the number of tests conducted drop dramatically.
But even in the NHS, that's why I'm particularly picking on the NHS, even with NHS staff.
Yes.
Fewer NHS staff were being tested, even though they're going to work every day.
The Pillar 1 NHS swabs isn't NHS staff, it's predominantly NHS patients.
There
will be some NHS staff in there, but the regular asymptomatic testing of NHS staff will be in the mass testing line.
Right, okay, so that's good, that's gone out. So, but the NHS swabs, that's for patients doing, so that dropped because outpatients dropped, presumably then? Largely, because it would have been the testing.
I would have to come back to you with all the full detail because that cost is managed through the Pillar 1 team in the NHS. I don't know if Shona Dunn has got more detail that she could provide.
Ms Dunn?
I don't have any more detail than you do have, Baroness Harding. We'll absolutely come back with more.
If we can come out. And then antibody testing. I mean, perhaps you can explain the rationale for antibody testing for that budget of 220 million, but then only 36 million was spent.
Yes, so this is as the science and the understanding of how immunity develops for COVID. So when I first joined last May, there was great hope that antibody testing would provide a means of accurately assessing whether or not you had immunity. And as we've all learned, and I'm clearly straying onto clinical territory here rather dangerously, that the behaviour of your T cells is just as important as whether you do or don't have antibodies. And so the antibody testing budget has not been spent because the science has changed and it's not been able to be deployed in the way that people had originally thought.
Dr Harries, have you got anything
yes,
scientific to add?
Although I would say going forward, actually antibody testing is likely to come back on its own because now we have vaccines, of course. It's important that we understand who has had a good response, for example. So a clinically examined vulnerable individual who's immunosuppressed. Then, so we will see more of this. So there is, in the pure budgetary terms, I think it's probably better if we come back with the detail, but absolutely recognise the scientific approach, which was we didn't have sufficient tests to do.
So what you're saying to me, simply, if I put it in simple terms, Baroness Harding, is that 220 million set aside for antibody testing in around May, when you set up, was set up then. It wasn't, and in November, even when you bid for more in November, that was still a budget line.
And things have been moving.
So it wasn't that you bid for more in November for that particular budget line. So that budget line stayed the same, but then you didn't need it because of the science.
And let's be clear on all of this. We agreed a funding envelope with the Treasury to make sure that the funds were available based on a range of different possible paths for the disease and government policy. This is in some ways quite a strange conversation because what we've demonstrated is that NHS Test and Trace was able to adapt based on changes in government policy and changes in the disease and not spend money unnecessarily. And I think that's a good thing.
I mean, but normally, this committee is always keen to see money saved. Normally, we would expect somebody running a budget this size to be, much closer to what they predicted.
I understand.
This is the biggest out-of-kilter budget I've ever seen in a decade on this committee.
I understand, Chair, but these are not normal times. And of all the things of NHS Test and Trace, it is an enormous new national citizen service that at the point at which we were discussing funding with the Treasury in November, the service was only 6 months old. In my experience of a wide range of citizen services, your budgeting and forecasting gets better as you build evidence and data upon which to forecast.
But you must have been fairly sure to ask for that extra £12 billion in November. It's a lot of taxpayers' money. That was mainly for mass testing, of course, which did come in at a later date. But it just seems that, I mean, what was your, just can you walk through what sort of modelling you were doing that you could go to the Treasury with a convincing business case for such an increase and get the money from the Treasury? It would be interesting to know what the Treasury's reaction was when you didn't spend it all. And I'll come back to Ms Dunn on that.
Well, we weren't modelling for a national lockdown at the beginning of the calendar year. And we were modelling for testing numbers to continue to grow and large-scale mass asymptomatic testing to be rolled out because people were going out and about us in a more normal way. And we were also, just in the same way as Mr Marron's described on PPE, modelling in such a way to ensure that we had the flexibility to adapt should the disease change its course or government policy changed. You rightly pointed to some of the successes of the programme at the beginning of this hearing. We would not have been able to react to the need to test hauliers at the border on Christmas Eve without having flexibility in both resources and funding. What you've seen is that we've reacted both ways, that where we've needed to immediately put resources on the ground, we've had the flexibility to do that, but also where the disease has changed and we haven't needed to spend the money, we haven't spent it unnecessarily. And I think that's a sign of a well-managed budget in a crisis rather than something that is wrong.
It feels like the taps were turned on regardless, and that there's not been proper financial controls. Perhaps I'll go to Shona Dunn on this, because overall...
But may I just say first that what we're showing is a slide where the taps categorically weren't turned on. The potential to have the taps on was there, rightly, in case the disease went in a different direction. But we didn't turn the taps on.
In Whitehall terms, and maybe Sir Chris or Shona Dunn will come back on this, but in Whitehall terms, there's contingency and there's a special money, but the Treasury can turn the taps on if there is a crisis. So perhaps the lorry things. We recognise that capacity needs to be there, but you've had surplus capacity for much of this. So test tracers, for example, massively underused, 1% last summer, up to even less than 50%, even at peak, 11 to 49%, I think is the more recent figure. So you've had that capacity paid and underused. You could have ramped that up potentially for the lorry drivers, but why was it that it was put into your budget and not there some discussion with the Treasury? Perhaps I'll ask Ms Dunn, because it's more of a Whitehall issue, and then I'll come back to Baroness Harding. Shona Dunn.
So, Chair, exactly as you say, Treasury, of course, are very interested in the quality of our forecasting, very interested in our modelling, and have a strong interest in making sure that as far as we can, we are coming in as close to the budget that we set. But Treasury colleagues at the time, David Williams was the accounting officer, but I think Treasury colleagues at the time absolutely recognised the exceptional circumstances that Test and Trace were operating in, and the expectation at the time of both the substantial increase in PCR testing that was being modelled and the massive asymptomatic testing plans that were being pulled together in November. And I think the uplift in November was from 15 billion to 22 billion. I think that 7 billion was specifically about those two things and an expectation that they would happen. And as Baroness Harding has said, through December, January and into February, circumstances changed very, very substantially. And that's why a significant chunk of this money wasn't spent. And Treasury, we've had this conversation, I've had this conversation in the last few months since I have been here. They understand the circumstances that were faced. They understand the very rapidly changing operational position and policy position. We've been through in significant depth where we have underspent to explain all of the different elements of that coming through. And we're talking to them about how we are using the learning that the organisation has developed over recent months, and the information that we now have, the data that we now have, to improve forecast modelling going forward.
So how much of this was because the Prime Minister had stood up and said, we want a moonshot? Baroness Harding.
So
I've just gone, if we go through the reasons for the underspend, there were a series of activities that were cancelled because of moving into lockdown. There were a series of activities that were delayed.
But the Prime Minister made an announcement about having a moonshot, throwing money at it, didn't he? And that was then fell to test and trace to deliver.
If I could, let me just take you through the three pieces. The mass testing, the universal offer for everyone to have access to 2 lateral flow tests a week, is the 1.7 billion that I referred to is predominantly that shifted from early in the year to after we came out of the full restrictions of lockdown. So it's a timing issue. And
can I just be clear? I was going to ask actually about that. Did that money get shifted from one financial year to the other? Because
yes.
you already had allocated money.
So the 1.7, I described 3 elements.
So it was
the 1.7 billion pounds would be moved into Dr. Harries' budget for 21-22, and as we all now are able to access 2 tests a week as citizens.
Okay, but to be clear, that money was because the Prime Minister made an announcement about the moonshot.
No, our plan, and as set out in the government's winter plan and then the NHS Test and Trace business plan, was to roll out mass asymptomatic testing first to high-risk workplaces and then to all citizens, which is what we did. But we delayed the rollout of the universal offer to everyone because of the national lockdown. That's the reason for that underspend in the year.
Okay, I mean, I remain concerned, though, that we have a budget underspend of this magnitude. I mean, let me just take another couple of areas of the spending. Laboratories, which has been, to some extent, a success, though we're going to touch on some of the challenges that around that as well. But that was an underspend. Is that because fewer tests were going through laboratories?
Yes.
To be clear.
So,
okay.
so the good thing about laboratory testing, in fact all of testing, is most of the costs are variable. And so we don't need to incur them unless we really need to use the tests, and that's what you've seen.
And it's odd to say relatively small in comparison of millions of pounds, but innovation and partnerships were increased by £3 million, which is small in the 37 billion allocated overall. Why was that? What's innovation and partnerships? Can you tell me what's involved?
That's the work continually looking at improving and working in partnership to develop new testing technologies and methodologies.
It's science and testing.
Yes.
Not with.
So if we've been one of the very first countries in the world to scale lateral flow testing. We've worked through the course of the last 12 months with a variety of different technologies to work through which tests could be more effective, more efficient, lower cost. That's the R&D budget, if you like.
I'm going to bring in, so Chris Wilmot's the accounting officer for the department as a whole. I mean, in your career in Whitehall, which is long and distinguished, so Chris, have you ever seen a budget so out of kilter?
No, and I've never dealt with a giant pandemic before either. Now, the approach that we have taken across government, and in fact we described in relation to PPE the last time I was here, and the Treasury has been our partner in this. We have not been at loggerheads at all. Has been to ensure that we can deal with the worst of what can happen, both financially and in terms of the pandemic. It goes back to the answers that were given to Mr. Smith on our approach to PPE, which Jonathan described. We looked at a reasonable worst-case scenario, bought for that, which gives us a 90% chance of having too much, by definition. We took the same approach to finances. So we were, and the Chancellor was clear right at the beginning that we would have the resources that we needed to tackle the pandemic, and budgets were set accordingly. We knew the risks that there would be significant underspends. We didn't know they were going to be of the size you've described, which were drawn up for the reasons that Baroness Harding suggests, but all our discussions were on the basis of we couldn't be in a position where we couldn't fight the disease for lack of resources or lack of approvals, all those sorts of things, and those were the discussions that we had with the Treasury. So yes, it is unprecedented, but also in an unprecedented situation. Now, I do think, back to your core question, it is considerably better to set a generous budget and then where we don't need to not spend up to it. That is clearly better for the taxpayer.
We're a committee that's always happy to see taxpayers' money saved. But however, in January, only in January of this year, we were told that this budget would hit 21 billion by the end of the financial year. And that was in January when we were going into lockdown. We'd had the Christmas issues. So that's a big shift in a
Yes, it is a
very
big shift,
short period of time. So how can you explain that? I'll come back to Baroness.
Well, I mean, I think the Baroness has explained it.
But the predictability of some of this was there in January, surely.
No, I don't think that.
Because we were in lockdown, we were moving into
maybe
lockdown, the modelling would have shown that you would
I
have
really
people
don't
isolated.
think it was. The government hadn't made a decision to not roll out mass asymptomatic testing at the beginning of January, and my programme was still working to the government direction at the time, which was to prepare to roll out mass asymptomatic testing to the whole population. That decision was taken through the period between January and March. So no, I don't think it was possible to have foreseen that. And operationally, it was important that we were able to respond to whatever those government policy decisions were and the course of the disease itself.
But at that point in January, we knew schools had closed, we knew people were instructed to work at home again. So what were the discussions that were going on about mass testing between you and
Well, actually, between Christmas and New Year, my team was rolling out asymptomatic testing into schools. So we were in full-on rollout of mass testing in early January rather than in slowing it down at that point.
Okay, right. So Chris, on the same point.
No, I'd agree with what Baroness has just said.
Okay, but this is money. I mean, one of the other concerning things is, of course, we want to see taxpayers' money saved, but that's because it can be spent whichever government's in power and somewhere else. So this is money that's been foregone for other parts of the system. I mean, what conversations have you had with the Treasury about this? I mean, as a county officer for the department as a whole, have you had some uncomfortable moments as they've challenged you on this?
No, as I say, we and the Treasury have been clear partners in this. I mean, Shona's been having the conversations recently, and this is emergency funding. No, this is not something that you can you would normally reallocate to other purposes. It is, as I understand it, money the Treasury is raising specifically for this purpose. So I'm not absolutely sure. I mean, in a normal budget, you would be correct. But in something, and I think Marius might want to confirm, in something which is being funded for an emergency, I don't think there is a reallocation question. It would be a we wouldn't raise it question.
Okay, Ms. Dunn, so you hadn't drawn it down, Ms. Dunn, is that right?
The funds are fully available to us.
Yes, that's what I thought.
Fully available to us, and we have, as Chris has said, been having those conversations in a very, very transparent way. And in the Spirit Partnership, we have these conversations with the Treasury all the time. So wherever information comes to us, we are very rapid in sharing that with Treasury. And that's the way we continue to run this. So,
Ms. Dunn, did you consider sort of bidding for a window, a range of costs? I mean, when you were as a county officer trying to make sure that this was held tightly to account for taxpayers.
So the discussions at the time. I wasn't personally involved in the discussions at the time, but the discussions at the time going to November were focused on the test and trace business case at the time, the modelling that was done, the demand modelling and the cost modelling that was done to support that was done very much with an eye, as Baroness Harding has said, to the full range of circumstances we might meet, and also to meet the peak requirements of those. So as both Chris and Dido have said, we weren't judging needs to an average or to a central point at that point in time. We were making sure that we had whatever resources were necessary to deal with whatever circumstances we faced as rapidly as we possibly could. So certainly there were models that gave us that range of figures, but the figures that we put forward to Treasury and were accepted helped us deal with that full range right up to peak scenarios.
Okay, so the Treasury knew about the range, the lower and the upper amount of what might be spent.
I wasn't involved in the detailed conversations at the time, but they had full access to the information that Test and Trace were developing.
Well, of course,
based on
David Williams would have been responsible at that point.
And yes, and he had. I know that Treasury had full access to all of the information coming from Test and Trace, and so understood the basis of those assessments.
Okay, before I go to Dr. Harries briefly on what some of the challenges are for this financial year, I just wanted to ask about the Leamington Spa lab, because obviously the labs is one potential element of prize from what comes out, which we'll talk about a little more later. But is it ready yet? Is it completed? And has that contributed to the underspend because it's been a bit late arriving?
So the Leamington Spa Lab is up and running, and pass the baton over to Dr. Harries to give you a full update. And you're absolutely correct that it is part of the future infrastructure that the country will have as a result of all this work. Like any other laboratory, the number of tests processed drives the cost. So there's been cost saved because there have been fewer tests processed. But Dr. Harries, do you want to...
So it's up and running and processing tests. It's not up to full capacity yet. That will come on over the next couple of months.
So that's contributed to the underspend.
Yes,
as part of the avoided through lockdown costs, possibly. No.
Yes,
4.3 billion.
There'll be a relatively small contribution because it wasn't planned to be on at large scale in 2021.
Okay, it was due online in June or May or June this year.
I think
so it might have been into this financial year.
Yes, that's correct.
Dr. Harries.
So I think you're asking about the longer term legacy.
Yes. So we now see we've got the questions that Ms. Olney was asking about the Delta variant. So all well acknowledged. We don't need to go through their figures again, but we're going to have release, of lockdown, a spreading variant.
Yes.
Lots of challenges for test and trace. And lots of potential. Well, how are you managing the cost, and what's your projections on the cost, given that you've got this large sum of money allocated?
So I was listening to the conversation. It is extremely difficult, and I was feeling for Baroness Harding because actually all of the data and the demand has been modelled against SAGE modelling effectively. And if many of you I know will have been watching that, and there is a high degree of uncertainty even with the best modelling. So when you then translate that through to the logistics and the throughput of tests through a laboratory, it becomes extremely difficult. So just in the last week, we've had a 20% uplift in the number of cases that need tests that need to be processed. So there is, hence, some of your comments earlier about underutilisation of laboratories. It is actually important, firstly, to understand that labs need to be working safely. In our case,
we recognise the 80% threshold.
Probably 70% actually when you do that, and when they're peaking, which they are now, that means we need to have thought several weeks back of bringing on new capacity, which we are doing. So we are stepping up that capacity in an approach which we can share those predictions with you, but it will never be. It's difficult to predict with the precision that you want.
What's the window on the budget? Because obviously the figures we're quoting, I should stress, are not audited figures, and that will come through in the department's accounts in due course. But what's your expectation about the budget range and what target you will hit on the budget? Will you be more within target than this 40% variance?
So I think it's extremely difficult to say because it is driven by the number of tests which are going through. And the tests actually cost different amounts. So we obviously, if we're using Lighthouse Labs or we're using private additional procurement, and we'll use obviously the cheapest one first and then move on. It's extremely difficult to predict the cost going forward because we don't know when or what the peak will be. But
you must have modelled for options. Given what you know so far.
We're modelling the numbers, and then we procure the additional testing depending on what is available within the time frame.
Okay, so even with all the Lighthouse Labs and the NHS's resources, you're having to commission new private lab support?
Yes, that is part of the planned step up. And of course, this is part of the challenge going forward of how do you plan for a pandemic when you need to pull on tens and tens of thousands of tests at very short notice. So there is a full model, but the costs will accrue depending on which services can be brought in at which times.
Okay, last couple from me. One, I just want to be clear. With test and trace, now Baroness Harding's gone, you're in charge of the UK Health Security Agency. So who's in charge of test and trace right now?
So I'm in charge of test and trace. The UK Health Security Agency comes into formal operational being from the 1st of October. And in terms of the budget, Shona remains the accountable officer.
Okay, so even though you'll be in charge of UK Health Security Agency, so as done, you're in charge as accounting officer.
I'll be the SRO overseeing the finance.
But the finance is down with you, Ms. Dunn.
So I'm the relevant accounting officer until the beginning of October.
Okay, and you become accounting officer at that point. So in terms of you're running test and trace yourself, but once the UK Health Security Agency comes in place, will you have somebody else looking at test and trace, or is that going to be one of your main
test and trace, so the Health Security Agency will have in it the whole of test and trace, including the Joint Biosecurity Centre, which has come in. It will have all of...
So I've just been clear, so in terms of day-to-day operations, you're going to be in charge of test and trace from now for the foreseeable
future.
Yeah, okay. Right. So it's rolled into everything. So you're the main woman in charge of
Absolutely.
all of that. Okay, that's just helpful. Just my final question to you, Baroness Harding, before I pass to Mr. Clark. The use of tracers. You've had, we won't go through what we discussed last time about the low take-up. Mr. Gardner touched on the numbers that you were expecting and then that you got. There were all sorts of issues there. Did you look at how you could flexibly recruit them so they could do other things? Because we understand from what the NEO have looked into that it was difficult to change their contract once you'd got them on space. There's, for example, we've had a lot of discussions about border security and checking at the border. We had a lot of people available and trained up. So what's the flexibility within that team? And if looking back, do you think you got it right, and would you do it differently?
Yes, it's one of the things that the team, the commercial team, have been able to renegotiate in the course of the last year to give us more flexibility. So as we said right at the beginning, the SAGE modelling was for 30 contacts per person, and we had to stand a service up in 3 weeks flat. And so there was limited flexibility initially. We've since been able to renegotiate those contracts so that it is possible to both increase and decrease the numbers of contact tracers in the national teams far quicker. I would just, though, remind everyone, I know you know this, but these are human beings we're talking about, who have employment rights, need to be trained. There will always be a time
my point about
lag.
Flexibility is if you've got, the NHS has bank staff, for example, that teenagers across London are working in the NHS on bank staff, but there's a flexibility there where they're deployed where there is a vacancy, and that many of the organisations which we'll touch on who do this, that's how they employ people, regardless of whether that's a we're not going to discuss the employment practices, but that happens.
And that's absolutely correct. And those sorts of flexible arrangements are now in place. So, for example, for our call centre staff, over a 4-week period, we can now flex up to 50% up or down, and over an 8-week period, up to 100% up or down.
Can they be redeployed to other areas if you had to send them to the border?
Yes, and the border policy has meant actually much more work for people from their living rooms and kitchens calling, and the teams have been able to flex across the whole of the contact tracing and quarantine services. I would just say, though, the speed at which the virus changes, and therefore the importance of having spare capacity, makes this a very unique situation. So you saw in December, we went, the volume of people needing to be reached by our contact tracers grew by fourfold over the space of 3 weeks, and then fell again by 85% over the following 3 weeks.
So my final question was, were you having any discussions? You had a hotline to number 10, you were appointed directly by the Prime Minister. Did you discuss anything around border control and what test and trace could do and what these tracers could do at the border when you took over the summer?
Last summer, no, I was not involved in border discussions last summer personally.
Okay, you didn't, so you had no discussions at all?
Personally, I was not involved in border discussions.
Did anyone in Test
summer.
and Trace have those discussions? Obviously that's not a trick question because you might have been somebody somewhere, but not that you know of. Yeah,
given that
it wasn't that you deputed
at peak
someone
there were
else.
55,000 people working in Test and Trace. Right. I'm not sure.
But you hadn't deputed somebody to go to...
No.
Okay, that's just...
No.
Mr. Clark.
Thank you very much indeed, Chair. Just one question to Baroness Harding. You've clearly learnt a lot during your year in post. Why did you leave on the 7th of May rather than later in the pandemic, perhaps when the new organisation was going to be created in the autumn?
Well, one of the things I said last September when what was provisionally called the National Institute for Health Protection was set up was that I intended to help recruit a permanent chief executive and chair, and that I didn't intend to be either of those two people. So I left at the point at which a chief executive and chair were appointed and a sensible managed handover had been completed.
I mean, Dr. Harris is very experienced throughout the pandemic, but you specifically on test and trace, aren't there experiences that you could have brought to bear for a few more months?
Well, I spent a month working hand in hand with Jennie, which in the total life of NHS Test and Trace is actually quite a large proportion of its life. I'm also still here, as you notice, 2 months after I've left, and I'm incredibly proud and view it as a huge privilege to have served in the COVID response, and I'm always there if Jennie and Ian Peters, the chair, need any help or advice.
Thank you. And there is a question of continuity, and when you've appeared before my committee, we've been concerned that some of the directors, the director of testing and the director of tracing, they've changed in some cases several times within the last year, which hasn't been helpful. think. But let's perhaps leave that for another day. And I've got a question to Dr. Harris about the app. You mentioned a couple of things about the app. In the National Audit Office report, they say the week commencing the 22nd of April, 16 million people had the app fully or partially enabled. Can you bring us up to date with what the latest figure is?
So I think it's over 25 million, but people will, obviously that number will vary as time goes on. And I do think actually it's important just at the moment to remind people how important it is to keep the app running. It's an advisory piece of information in terms of managing the pandemic.
Are you sure that is the app fully or partially enabled rather than download it?
I believe that is the case, but I will get a number for you for today.
Okay, this is clearly very important, and it's you mentioned it earlier. There is some concern about the role of the app, and in particular this extension by a month beyond the 19th of July of people needing to isolate. There are some suggestions that people might be either deleting it or stopping it being enabled. I assume you're keeping an eye on this. Are you? And you must have literally. One of the good things about technology is every minute you can tell what the number of downloads and enabling is. What is the trend?
I don't have that figure with you, but we will get that for you. But the key point I think that you're making is, I would like to just challenge this word of the extension of the contact tracing, because in fact what's happened is we're not ceasing isolation. Right. It's continuation of an intervention for a particular reason to that point. And the point is that when we get into the middle, particularly the end of August, we hope that we will start to see a turn in that peak, that we will have nearly 75% of the adult population doubly vaccinated, which gives a completely different degree of protection to the one that we have at the moment.
I understand that. I think a lot of people in the country, when they heard the Prime Minister talk about the terminus date, reasonably expected that might extend to the need to isolate in receipt of a message from the app as well. But you may not have the exact figure. Are you aware of whether there is a reduction in the number just in the last few days of people with the app enabled?
I am aware that people are choosing not to use the app, hence my point at the start, which is it is very important. And I think it's important for two reasons. Firstly, the one I've just given, which is we're seeing a rise in cases. So this is not an inconvenience. It's actually to alert people to the fact that they have been a close contact and they may be at risk of becoming infected themselves and passing that infection on to other people. The second one is that it's good to have that there for advisory reasons. We can pass information to people. It's the quickest way. It's 15 minutes to get information to people. It's often the easiest way in some areas. So, for example, large numbers of cases in younger people, in young adults, often in hospitality settings, for example, in the cases where you wouldn't necessarily be able to contact trace easily. So there's some very good reasons why you might want to keep that app running. And we know, as I think Baroness Harding said earlier, we know that up to about, difficult for the numbers which she said, but 500,000 cases have been detected that way and transmission chains ceased.
But I think you've hinted that there are going to be some changes to that, and they presumably reflect the fact that the context changes. If someone has been double jabbed, then they will feel, perhaps not unreasonably, that the threat is less than during the raging height of the pandemic, in which very little of the population.
So this goes back to public perception, and the whole of the test and trace service and all the different parts of it are a need the public and the system to work with them. It's the same for the whole of the pandemic response, actually, all of the non-pharmaceutical interventions. So, and social distancing, it is a partnership to support the population to get through the pandemic.
I understand that.
And it comes back to my point about the balancing of the four pieces of weaponry that we have.
Yes.
So you are completely correct. As one of those pieces of weaponry expands, as Jennie's described, we of course keep under review how we use the other three. and therapeutics, as they increasingly play a part, will do likewise. And that's why we're able to take some of the decisions that we did.
Well, I was interested in what you said, Sir Chris, on that balance there. And clearly there is a balance. There are two sides of the equation, and there is the isolation that is imposed on people, extended for another month, including people that are jabbed, versus the impact on hospital admissions. Obviously, as the Permanent Secretary, you must be familiar with that data. So, what are your estimates of the number of people that will be required to isolated as a result of extending the isolation requirements till the 16th
Sorry,
of August?
it's not, as Dr. Harris described, this is a continuation of the
Correct,
existing
absolutely.
policy to a
So for that
date.
month, from the 19th of July
I don't have that
16th.
exact number with me, but the point is that as vaccination rises over that period, we are able to turn off some of our other interventions.
But you've described making a balance, and if you're making a balance, you read the scale. So
I don't have the specific number you're after with me.
If
We'll
I could
check.
come in on that one. I mean, at the moment, the cases yesterday were around 33,000, and on Wednesdays they're sometimes slightly different, but they are rising. So it will change on a day-to-day basis, depending on the steepness of the curve, what the estimate of the number of contacts is.
when the Health Secretary talked about 100,000, is that a figure that...
I think that was a potential peak figure.
Right.
As I said, and I know some people are quoting 5 million contacts, but of course, if you actually you can work out what you think it might be for each stage of the cycle.
What's your central estimate?
Well, it depends where you think this peak is going to be. But if you say for every there are 2.4 contacts on average, which was the question we had earlier, 2.4 to 3 contacts for every new case. But then you have to assume how many people are using the app to take that through, and that will depend on it's a different age group. So it's a very difficult one to do because you'll have a changing age prevalence on a day-to-day basis as well.
Of course, but to make a judgment, you must have a feeling for how many people, an estimate, more than a feeling, an estimate for how many people are going to need to isolate as a result of that, to compare, which we understand is the logic, against the increase in hospital admissions, that if you didn't do that.
So I think the other point is about, as I've said, this is an extension of existing policy, and the decision around that policy end happens next Monday. And one of the reasons for the extension is partly for the vaccine coverage, because that will also impact the number of people who will become positive as we go forward. So as the vaccine rate is changing, the risk of somebody becoming an infected contact also changes.
Prime Minister and many others have said it's data, not date. So what is the data?
Well, you could work, it depends on how many people have the vaccine as we go forward over that period.
So an assessment has been made, as Sir Chris said, to whether it's delay or not remove the requirement for isolation by a month.
Quite apart from modelling every day on everything, the issue here is we are still monitoring the hospital admissions, because I'm sure you will have seen that hospital admissions, whilst much lower than they have been, have started to rise. And so actually, rather than be calculating that day, the bit that is really, really important is whether our hospitals are going to fill and whether we are going to have deaths.
Completely understand that, and obviously it's an important equation to balance. But I think the implication of it being about data is that we get to see the data and be able to scrutinise it as parliamentarians. But let me ask, we've got a number of things to talk about. Just in terms of the NAO report on lateral flow tests, the National Audit Office said that NHS Test and Trace forecast that by the end of May 2021, 655 million tests would be used. Do you have an estimate of how many have been used?
So we don't, and you'll see from the report that the registered test is 14%. If you actually take out the numbers of tests which we know are, if you like, in transit or in store, that figure rises to 20%. but surveys suggest that more than 40% of people are using the test there, and it's difficult to estimate beyond that. One of the points about the use of the test has been it's a new technology. We have pushed it out clearly earlier before I joined Test and Trace, but we've absolutely pushed out the test at a time, partly, as we discussed before, to cover those very high-risk settings like care homes. And as time has gone on, in order to understand better what the utilisation is and be clear about the value of utilisation, we're turning over into a pull mechanism so we can be really clear. The other thing that we've been doing is putting in much tighter logistics, if you like, practice, so that as you pull through the system or as we deliver to a home, you can see how many of those tests are coming back and being registered. But at the end of the day, we know that many people are using them and not registering them. It's very difficult then beyond that to know. We can tell you how many have gone into each setting, for example, into each channel, whether it be schools or care homes.
I think my colleague Sarah Oldham might have some further questions on that. And just finally for me, perhaps to Baroness Harding, as has been said, we have people testing positive for COVID. I think yesterday there were over 30,000 people testing positive, up from 5,000 at the beginning of June, increasing exponentially. Now, in autumn of last year, you made a business case for the extra funding that we've talked about, that it would be used to prevent a second lockdown. It's pretty evident, is it not, that were it not for the success and effectiveness of the vaccines, we'd now be in another lockdown. Has that revealed that the aspiration for test and trace to prevent lockdowns has evaporated?
Well, I think this just takes us back to what Sir Chris was saying, and I said at the beginning, which was test and trace has always been one of 4 main planks of our COVID response, not the single one. So no, I'm afraid I don't recognise the way you described that.
To quote from your business plan, NHS Test and Trace aims to avoid the need for a second national lockdown. Were we placing too much weight on the potential for Test and Trace to avoid that?
If the NEA report itself sets out that Test and Trace's objective is to help break the chains of transmission, and in doing that, obviously, we would all hope that of the 4 interventions, frustrating and difficult it is for individuals to isolate, it is clearly less damaging for the population as a whole than large lockdowns. But large lockdowns is one of the 4 tools that we had to use as a country, the government has to use.
Was it just a bit over-optimistic of you to have it put in the business case? Is quite a gung-ho approach.
I think that, again, look, it's sort of 2 months since I was in the thick of it, as it were, and you sort of step back with just a bit of distance, and you can understand why this time last year no one thought that vaccines would be deliverable.
No, that's not. No, sorry.
Let me. I will get there. No one thought that vaccines would be deliverable. I think it's not actually that surprising that the whole country wanted to believe that we could beat COVID without having to do the incredibly unnatural, difficult things of lockdowns. So I think it's not just about...
Who put it in the business case? Was that your decision, or was that driven through Number 10?
I refer back to the business plan that were published, which is really clear that the test and trace role was to help break the chains of transmission.
Okay, but the bid for the money was that it would avoid a lockdown.
Well, I don't actually think that that's the essence of anything that I've ever said. I've been to this committee before and to many other select committees and said again and again and again that test and trace is one of the elements of tackling COVID. It was never set up to be the single-handed tool and never could be. And if you look at every country in the world, that is the case.
What it did say.
Procedure is important here. This was in the business case that requested an eye-watering sum of public money, and it was justified on the basis, I'm quoting from the NAO, that it aims to avoid the need for a second national lockdown. That was an important contributor to getting the money. So I think it is reasonable, especially for the Public Accounts Committee, to to reflect and to ask whether that was an accurate representation that had been made.
And all I'm just saying, Mr. Clark, is that the government policy was that test and trace was one of the elements, not the only element. I don't believe that the Treasury believed that test and trace was the single-handed reason that we would fight COVID.
Who owns the business case? Was it you, or was it Shona Dunn and the department? Just to be clear, that signed up to bidding to the Treasury on the basis that Mr. Clark's just outlined.
So, Chair, the business case will have been the business case will have been put forward by the department. The business case will have come forward from Test and Trace. It will have been considered by.
So, who signed off that wording then? If it was one of four, why wasn't it described as one of four things?
The business case will have been signed off by the accounting officer at the time. David, I'm absolutely certain, as Baroness Harding said, that the Treasury was under no doubt whatsoever that Test and Trace was only one element of the response, and would not at any point have thought that there was a suggestion that they were the sole answer to avoiding a further lockdown.
Okay, well, we refer everyone to the National Audit Office report, which highlights the facts on that. But I'm going to go to Nick Smith, MP. Mr. Smith.
Thank you, Chair. And shortly I'll go on to the issue of consultants, but I want to take a quick deep dive into a little bit of the detail of the report. On page 47, figure 17, for the period between March and 1st of April, there's a big dip in the test taken, and I just wondered, Baroness Harding, if you please give us an explanation of that. Is it a data thing? Is it an ops thing? Is it some other
That's
issue?
the school Easter holidays.
So it's straight Easter holidays?
Yes. So just looking at it, eyeballing it, it's a reduction in substantial reduction in lateral flow testing, and we know that in the first during when schools went back at the beginning of March, they did an outstanding job at testing. Not unsurprisingly, once our teenagers went back home for the holidays, we saw a dip in the testing volumes that then came back up again when schools went back.
Okay. All right. Anybody else? That's pretty obvious. Okay. Thanks. Chair, now turn to this vexed issue of use of consultants. It seems that they are over 50% of the staff total at the central office, close to more than 2,000 people. They've got very high day rates. Some of them will have earned over £200,000 this past year, some 300,000. We just need to dive into this a bit more. Baroness Harding, why are the numbers of consultants employed by NHS Test and Trace higher in April than they were in December, despite your plans to reduce them, please?
Sure. Firstly, I don't recognise the sums of money that you've just described for individuals' earnings. I think we have to be careful that we're not just multiplying by assuming that people are working the whole time. In terms of...
So what would you say the highest...
I don't have a figure, I'm afraid.
Because I think there does need to be clarity about this. Will you let us know how much...
Well, Dr Harries will have to now.
Yes, I'm afraid I can't, but
right.
I refer maybe to Shona Dunn could describe what is and isn't possible.
How many of those consultants, Shona, will have earned over £200,000 since March of last year?
So I don't have the figures for individual consultants in front of me. I think we have issued information which says that the average day rate for our consultants and contracts have been £1,100, and the NA report and other sources cover the spend on our top consultants' contracts. Undoubtedly there will have been a number of consultants, no doubt, that had higher than £1,100 day rates, but I don't have that information blow by blow in front of me. I'm happy to consider, Chair, what we can share with the committee, but obviously you'll understand the personal...
I appreciate, Ms Dunn, just I'll chip in there that it might be commercially confidential, but if we could have a reading room approach to seeing some of that information. We've done that with other departments and a lot on Brexit, and we obviously never leak anything, so if we could do that, that would be great.
Happy to talk to the clerks about what we can provide in that context, Chair, of course.
At the back of the envelope, count up for the last year on £1,000 a day would very quickly add up to over 150,000, up to 200,000 a year for some of these 2,000 people, I'm sure. Can you write us about how many people have earned more than 150,000 or 200,000 or 250,000 out of those 2,000 people in the last year, please?
So I will talk to the team about the granularity of the data we hold, and absolutely, as the chair has asked, talk about what information we can share respecting individual confidentiality.
Yeah, we wouldn't want to.
No, we have a well-worn route for doing this, Ms. Dunn, so we'll
and absolutely we will.
We'll go to back channels to sort that out. Thank you, Mr. Smith.
Sort that out.
And we wouldn't want to break any confidentiality, but do you know what? It can't be that hard.
Yeah, we know we have a well-worn route, so that's
okay. So back to my question, Baroness Harding. Why are the numbers of consultants employed by the organisation higher in April than they were in December in 2020?
Well, maybe I could just start by saying they are lower today than they were in April.
Yeah.
So today, consultants make up about...
So to come back to the crest.
Okay, sorry. I just wanted to give you that full context. You have to remember how much, and we've just been discussing it in the context of money, how much things have been changing, and how important it is that NHS Test and Trace is able to react very quickly. So we have had a plan in place since January with named SROs for each of the consultants to roll consultants off and replace with permanent civil servants. That process is not easy, if we're really honest. So we've run, up until the end of May, 523 recruitment campaigns to fill 1,894 roles. Of those 523 campaigns, 196 of them, 37%, have failed to appoint anyone. And those have particularly been in data, digital, operational and project delivery roles, all of which are skills that are in very scarce supply in the civil service in general, but actually in the economy as a whole. And as Mr. Clark was asking about me personally, but others, it's really important that we don't just focus on removing the consultants. We need actually the permanent civil servants in role. And in all honesty, that has actually been quite hard to do. At the same time, the demands of the programme are changing. So, I don't want to hand the problem to Dr. Harries as the government's policy is changing. That, in turn, right now will be changing the requirements. And as Jennie and her team are forming UKHSA, it's important that we're only making permanent appointments through proper due process. And it's only gradually becoming clear in some areas what the permanent structure should be. So this is a very long-winded answer to say, I don't think anyone wants a service that's this important to be dependent on temporary resources. Nothing against
it's over half the staff.
Yeah, so no one, well, it's 40% now, so it's going in the right direction. No one wants the service to be dependent on temporary resource, however good those individuals are and however committed they are. But it's also important that we make the transition in a measured and sensible way, and we recognise that some of these skills are skills that don't exist in the civil service, and we need to bring them in.
Okay, as you've had to lay off more expensive consultants, how have you, and brought in better value, cheaper consultants, how have you retained the knowledge from the earlier, more expensive consultants to make sure that, I know the job's changing a little, but still there will be important knowledge, organisational knowledge that will need to be kept.
Well, and this is, your question sort of implies the answer, really. This is the absolute challenge of managing this roll-off of consultants. So over the course of 4.5 months, 17% of the consultants have rolled off, which in any other public service would be a very, very large change that you'd say you don't want to push it too much faster. So it's important that you manage this in a staged way, that there are handovers, that you parallel run with people. and that we're really thoughtful about the skills transfer. And I have to say, I do understand the committee's concern about this, but I think it's also important to recognise, the public service that all these individuals are doing. I think they've all cared deeply about making sure that that knowledge transfer really happens and that people are available to those permanent appointees once they come on board to, even after they've left. And we've seen fantastic public service from those teams across the board.
I'm just trying to understand it a bit more, just because I'm a little bit afraid that things have got out of hand in terms of consultancy expenditure, because you've estimated you'll have a total consultancy spend of 195 million, but the indications are that you're going to spend 300 million on the top 10 consultancy suppliers alone. So I'm looking for sort of, more confidence that you're properly gripping this, really. I mean, paint a picture of what these 2,000 people are doing.
Could I possibly hand that over to Dr. Harries and to Shona Dunn, given that you're asking about the now as opposed to where we were 2 months ago?
A lot of this did begin under you. Will you tell us what you thought those 2,000 people... Tell us more about paint a picture. What were those 2,000 people
paint a picture. Well, as I've said, you can see it from the skills that have been harder to recruit into. The digital, the data, the operational project management skills. A lot of these are skills that in the wider economy, both in the public sector and the private sector, are done by people working on more short-term consultancy type arrangements. The IT sector is one that works like that. And so it has been necessary to bring in people with those sorts of skills who are used to coming in and working only on a project. So, and as the disease has changed and government policy has changed, it's been necessary to mobilise teams at very, very short notice where you can't give individuals clarity on how long the job is going to exist. So by definition, you have to make it a short-term appointment. So if I give you an example for that, the very rapid changes in which Shona Dunn was leading on border policy required us to stand up a borders team very, very quickly. Inevitably, that meant you had to bring in contingent labour, so short-term labour both. And we've used through the course of the last year temporary contingent labour from all parts of society, whether it's been the army initially, the civil service people on secondments. We've had a lot of volunteers who've come, people who've been between jobs have come on volunteer contracts, unpaid. And then we've also had consultants who've been paid that's part of what they do in normal times. So we've had to fill those short-term skill gaps, partly because some of the skills just didn't exist in the civil service, and partly because we couldn't say to someone, here's a permanent job. And I think the committee would quite rightly be very critical of me if I was sitting here now saying we had a lot of permanent civil servants who we were about to make redundant because we'd offered them full-time jobs, but actually COVID has changed, the vaccination programme has been an enormous success, and therefore their jobs don't exist. So we've had to use temporary people given the uncertainty that we faced.
I suppose I'm now looking at you, Dr. Harries. This change in operations, the different work that you have to take on board at short notice, do you think you're going to rely still on this high percentage of consultants between 40 and 50%?
So that's certainly not the ambition, and Shona may want to come in a moment, because we have a very detailed ramp-down plan, taking into account as far as we can predictions around where the pandemic will be and where the new organisation will be. And that is a staged plan, so it's looking forward over what we hope will be a wave now into the end of March, and then covering still the pandemic, and then obviously the forward flow of the organisation going forward. I think picking up some of the points, though, which Baroness Harding has made, it is quite challenging. So, for example, this afternoon, I know my next meeting will be to completely review all of the work we're doing, including all of the budgets and all of the skills and capacity that we need, because the changes in policy will mean very, very significant changes to the way we're working. So, for example, if we are not tracing as much, we have a potential drop down on that, but we have winter planning arising, and as COVID goes down, we may well have flu rising. So it's not simply about being able to replace on a long-term basis and ramp down. It's about continuously changing. And I think one of the things which perhaps hasn't been highlighted, we've just launched, so last week, a formal consultation. So we've got very advanced plans for the organisation for 11,500 staff. This is quite a big undertaking in the middle of a pandemic and as we build a new organisation, but it has great opportunities as well. The difficulty, one of the key difficulties is in retaining our staff, because many of them have come exactly contributing to the public health mission of managing and supporting controlling the pandemic on short-term contracts, and when just at the moment we're unable to offer substantive contracts until we're past the consultation period. So this is probably the most critical time of the organisation's development, where we are trying to ramp down staff. We are consultants, we have very, very significant policy changes, and we have the risk of loss of staff that we currently have. On a positive note, however, and picking up Dido's point, many people who have come into the organisation absolutely share a public health mission to protect lives going forward, and I think if we can just get past that, we have a great opportunity for the organisation.
Yeah, thank you, Chair. And we all accept that everybody's trying to do the right thing here, and they've got public service missions, of course. Ms Dunn, give us more comfort that you're going to wean the organisation off expensive consultants and get better value, please.
This is a really sharp area of focus, I have to say. So even just over the last few weeks, Test and Trace has been doing a really granular bottom-up exercise, looking at each directorate in turn, looking at, take as a given all of the things that that Jennie and Dido have just said about the unpredictability of the situation, but nonetheless, each directorate going through in great detail both what they're going to have to achieve over the coming month and the context in which they're going to be achieving it, and developing their workforce plan and strategy, which I am going through with them. They have very extensive plans to bring the consultant numbers down substantially between now and next March. As Dr. Harries just said, of course, those plans, there'll be further opportunities that come forward over the next month or so, and I expect to see those numbers come down a bit more. I'm keeping a very, very close eye on this, and not just on consultant numbers, but contingent labour numbers overall, and the committee can absolutely be assured that we won't take our eye off this ball.
So thank you for that, and we will watch it with interest. And the reason I asked the question, and the reason I'm sceptical, is this, and I don't want to steal Mr. Carden's thunder either, but about 2 months ago, I was outside the car park in the co-op in Blaenau, in my constituency.
We're getting to the important part of things now, Blaenau Gwent.
It's somewhere I stop off, usually on a Thursday night when I'm driving home, to pick up some pasta and a sauce for my...
Okay, I think we just... Okay, I'm sure this is winning you votes, Mr. Smith. We're actually going to cut to the chase.
It's a favourite retail spot for me, I can tell you, especially on a cold winter night.
Okay,
but anyway, do you know what? And I spoke to... There was a temporary testing site there, and there were about a dozen, I think, mighty staff working there, doing a great job, good people. But the truth is, there was very little footfall on that Friday afternoon where I was there. And I suppose my worry is, are you gripping the programmes that you roll out to ensure they're effective and value for money? Because my takeaway that afternoon, even though I'm very fond of the co-op in car park in Blaenau, was my sense was you weren't. So give us some comfort you're going to do that better.
I'll come in first, actually, on that, because I won't comment on your shopping, but you raise a lot of other points. There's one thing that we should say, that part of the whole point of creating UK HSA was to bring certainty to this operation and move it out of its entrepreneurial phase into this is a permanent thing with permanent jobs in it. So that whole process is part of that. And then the issue you have just raised, comes back to the discussion we had with Mr. Gardner right at the beginning of this, of how you balance traditional efficiency with access. So the question of, particularly when you're dealing with difficult to reach communities, having access everywhere, regardless of whether it is used all the time, is an object of policy. Now, I don't know if that's the case in the situation that you raise, but we certainly take the principle that, you know, if somebody needs a test, they ought to be able to access it easily, and we do not take the view that, you know, that one over there, even though it only gets a few, shut it down if that is providing access to
nicely,
a
actually,
community.
to
Yes.
Mr. Carden, if I can just
Yes.
chip in there, to Mr. Dan Carden.
You,
MP.
Dan.
Thank you, Chair, and no thunder, but welcome to our witnesses. Thanks for coming today. And Dr. Harries, could I perhaps start with you? And I think hearing from your experience as Baroness Harding and the ways in which you've tried to change and develop test and trace, I think you've both been at pains today to talk about the involvement of local authorities, the importance of devolving down. We've heard for months and if not years the desire to move away from consultants. And I speak to I speak to directors of public health locally who tell me things have improved over a period of time. There's been more engagement. But what they want is more investment in local public health protection officers. They want responsibility at a local level. And it just gets me thinking, is this not a design flaw that comes from day one, where we've tried to do something from Whitehall, from the top down, fragmented? You're renewing contracts with Serco this year for £300 million. The number of consultants remain too high, and when I look at what you've actually spent locally, about 2 billion handed to local authorities, 176 million for test and trace support payments, 13 million for practical support for self-isolation, 149 million for rapid testing. These are tiny figures. Isn't too much just being held right at the top, fragmented and handed over to the private sector?
Thank you for the question. Obviously, I'm trying to learn from whatever has been developed through test and trace and take the good learning of that forward and try and offer fresh insights as well. And for me, some of that comes from actually having been a Director of Public Health in several local authorities. So I like to think, and I think it's great, that I have a good working relationship with all of those Directors of Public Health, which is actively continuing now I'm in this role. And in fact, on Monday, I had the first group with a group meeting exactly to have this question, which is, how does national work with regional and local in the new Health Security Agency? What is the design for that? And I've asked actually them to come forward with different designs so we can contrast and compare between the Faculty of Public Health, the Association of Directors of Public Health, Solace and local government agency, and actually the one that we had forgotten from the room and decided we'd need there was the Chartered Institute of Environmental Health, exactly for the reasons that you say, because we recognise how important local authorities are, and that all health protection issues start with individuals, and we have lots of things we can do outside COVID to support the health, protecting the health.
You have the public looking at the vaccine rollout, saying what a success this is, led and delivered by our National Health Service, and the criticisms and the polling shows public dissatisfaction with test and trace because they see it as privatised and they see it as fragmented. Are you going to empower local authorities and not just have a better working relationship with them, but actually hand over more of your budget and allow them to employ more staff?
So just to be clear, we will have to make I will have to make a full business case in the spending review going forward for the new Health Security Agency. So I think that is something to come forward. And the agency.
Is that what you want to do, or do you want, or will it be maintained?
So I think what I want is a system which works best to protect the health of the population, and undoubtedly there is a key role for local authorities in doing that. And I would also venture to say that I think in the time that I know I've been in public health, in the from 2013, so a lot of the health protection skills actually moved away from local authorities, and I think there's an opportunity for us to support that. Now, quite what the model for doing that would be is one that we need to discuss, and I think my ambition would be to design with local authorities. But I think the other important thing is that the Health Security Agency also has a global, international role and a national one, and it is about getting the proportionate balance of that right across the whole system. So absolutely recognising local, but also recognising this is a UK national infrastructure.
Yes. Could I add, obviously, you're raising extremely important questions that we debate all the time, and as we've acknowledged, working with local authorities in this area is one of the areas that has evolved, and we have changed our approach. However, you're raising two slightly separate issues. So there's national versus local, and then there's contractors versus permanent employees. Now, on the national to local, you raised the question of vaccines. That is a very national programme. It's one of its great strengths. National Health Service, nationally procured, national standards, national access, same offer everywhere. It is not a given that local equals better. There are a lot of cases where it is, but there are also cases where national scale and that sort of vaccine approach are also extremely important, and that's true in test and trace. So what we need to do here is find the right balance of where are national standards, national entitlements.
National hasn't worked.
Well, you raised the question of the vaccine programme. That is a National Health Service programme run to national standards with a single national. Yeah, well, and this is where these questions are worthy of debate. So I'm not disagreeing with you that there is an absolutely vital local role, but there are also very important national roles, as the vaccine rollout shows, as it were. So I'm not disputing your question and the thrust of your argument at all. I'm just saying it's more about deciding what is actually best done nationally, as I say, to national standards, national frameworks, economies of scale, and where is that local knowledge that we've pointed to in a number of times.
So, for example, just to cut to the chase on that, so the testing and the logistics of getting testing is something that would have been difficult to have delivered locally.
Exactly.
But testing centres.
But even there, I think it's more sophisticated and subtle actually than that, and that's why this debate and raising these questions is entirely right. So local decision making on where to site testing centres, what hours.
I meant testing, I meant the labs really. So the lab structure and the barcoding of tests.
Absolutely.
That's a perfect.
And the data
but
architecture.
The testing centres, which I think Mr. Harding was referring to, are more local.
Absolutely. So at each part of the testing, tracing, isolation support process, it requires really quite careful collaborative thought.
Yet you commissioned the testing centres centrally, but Mr. Carden,
well, no, we don't actually. We work very collaboratively, and local authorities, the local testing sites are set up and manned by local authorities, and that's been one of the successes in reaching out to the more vulnerable groups in society, precisely because we recognise, just as you say, that local authorities are likely to be the best at reaching those communities.
Yes. And just to be absolutely clear, we are not saying we have always got this balance right.
No.
Which is why your questions are important.
Just to evidence that balance working dynamically at the moment, where we have Local Zero, which is very much about giving local authorities the control of the tracing. Actually, some of them, because of the sharp rise now, need to hand some of that back because it needs national capacity. It's overstretching local capacity. So I think the really important thing here is about flexibility and recognising the value of both national and local working together.
Can I just move on, because I did want to ask about contracts, and could I ask Shona Dunn, I think he would be the right person to just, how have you managed conflicts of interest in the handing out of big contracts?
So all contracts that have been let during the pandemic have been through the same procedures that the department would normally use. We've had some exposition of those, but all of the due diligence you would expect us to undertake in terms of conflicts of interest, but also in terms of capability, value for money, technical meeting of the requirement, etc., have been undertaken with all of those contracts, and conflicts of interest are routinely recorded as part of the due diligence process.
I think there was a delay with many of the contracts being published. It's up to 5 months for the Deloitte contract being published. And I did want to ask about the Health Minister, James Bethell, who has links with Deloitte, and Deloitte seems to have some of the largest contracts, and as we've heard earlier, the largest number of consultants that are being... Is that just a matter that's simply recorded as a conflict of interest?